All right, welcome everyone. Today we're going to talk about endocrinology, pathophysiology. This is not going to be an exhaustive lecture, just the high points of the most commonly encountered conditions. We're going to talk about thyroid, diabetes, pancreas, adrenal, hypothalamic, pituitary axis. We'll touch on the aldosterone, but you're also going to hang on to it because we'll come back to that when we get into the cardiovascular system and talk about blood pressure and the other ways it can be affected. So let's get this show started right away. You have done some pre-reading, hopefully. And so what I want to know is when you encounter an endocrine disorder, what's the first question you need to ask yourself? What kind of problems are you likely to encounter based on your reading that you may see in terms of the endocrine system? It falls into three buckets. All right. Oh, also, if you have questions, just type them in the chat and I'll try to work them in. So your endocrinopathologies, your endocrinopathies, as they call them, fall into three buckets. It's either going to be too much hormone, too little hormone, or the body not responding to the hormone. And so those will be your hypo and hyper states. And so what do we mean when we say hormone excess? Well, hormone excess is when the gland or something is producing more hormone than the body needs. Often from an adenoma, that would be a benign hormone secreting tumor, or from autoantibodies that drive overproduction. So some examples you may have found in your reading and in your clinical course would be things like Cushing's syndrome, where you have excessive cortisol, or Graves' disease, say, where TSH receptor stimulation is occurring and there's excess thyroid hormone, or maybe a primary hyperparathyroidism where you have excessive PTH. And the management in these hyper or excessive thyroid states is you want to remove the source, and we either do that with surgery or setting it on fire with ablation, or we give a blocker or a hormone or an antagonist or an inhibitor of some kind. So what defines a hormone deficiency then? That means that the gland is underproducing due to some autoimmune destruction, maybe surgical removal, radiation, a genetic defect. And some examples of those include things like Hashimoto's thyroiditis, where you have a low T4 and T3, maybe from thyroid destruction. And remember those inflammatory lectures we gave when we talk about the cytokines? They're coming back again today. So that's why we started with them, because a lot of times, depending on the system they attack, causes the pathophysiology we encounter. Addison's disease, manifested by low cortisol and aldosterone levels. Type 1 diabetes, as you know, it's a beta cell loss leading to absolute insulin deficiency. So those inflammatory markers are essentially attacking the endocrine system, the gland, and we develop these deficient states. Well, in addition to a deficient state, you can be making enough, but the problem is something at the target is not causing it to respond. So you may be what they call hormone resistant. And hormone resistance, this can be present and it will show that you have an elevated, say, stimulating factor, but it's not properly responding. Think of it like the key no longer fits the lock. So an example of that might be something like, say, type 2 diabetes, where one of the major features is insulin resistance, right? Or you can also think about something like pseudo hypoparathyroidism, where you have basically resistance to parathormone, PTH, or thyroid hormone resistance syndrome. And that means you will often require higher doses or drugs that improve the tissue sensitivity. So we give medicines that may sensitize you to your own, say, insulin production. Now, why do we start here? Because every endocrine disorder, whether thyroid, adrenal, pancreas, or pituitary, can be sorted into these three diagnostic buckets. You either have too much, too little, or relatively too little in the form of resistance. So if you can master that framework, now you have a game plan to proceed into endocrinology. Okay. Any questions so far? Anyone feeling bewildered? If you are, put your hand up. If you don't want to put your hand up, type it in the chat. So let's talk about now normal thyroid physiology, right? What system regulates thyroid hormone production? Who's doing this? Well, this is the hypothalamic pituitary thyroid axis, the HPT axis. And this thing is the control tower for thyroid function. So where does this all begin? Anyone want to take a venture? You like endocrine? Tell me, what's the first shot across the bow that says, go, let the games begin? Anyone? Nobody. So what happens is it's the hypothalamus, and it's the hypothalamus that releases TRH, thyroid releasing hormone, thyrotropin releasing hormone. And what TRH does next is it stimulates the anterior pituitary to do what exactly? Well, it says, tell the pituitary to release TSH. And thyroid stimulating hormone goes where? Well, hopefully to the thyroid, what it's supposed to stimulate so that it can produce T4 and T3. Now, what's the difference between T4 and T3? One is the active form, and one is the form that gets converted into T3, which is the most abundant. So T4 is the main product, but it's less active. T4 is the thing we check when we want to diagnose hypo or hyperthyroidism. And T3 is triiodothyronine. And this is the active form. And it can become active in either in the liver, the kidneys, and the peripheral tissue. And it's acted on by a enzyme to remove an iodine, and so it brings it down to T3 and makes it the active form. Hang on to that iodine, because that's one of the drivers of pathology when we get to talking about thyroid disease. So how does the body prevent overproduction? All of endocrinology tends to work through what's called a negative feedback loop. That means the more active hormone in circulation, the less we trigger the release of more. So more triggers less, so that we keep this in balance, okay? The primary driver of a negative feedback loop is to maintain stability. That's different than a positive feedback loop. And the only one I know of, because I'm not an expert on all things, but the only one I know of that's a positive feedback loop is childbirth. Oxytocin begets more oxytocin. You contract and you push and you push and you contract. And the reason we want that is a positive feedback loop is designed to amplify a physiological condition. It's meant to intensify the labor to get the baby out. But a negative feedback loop is really looking to just maintain stability. So through the negative feedback loop, rising T3 and T4 signals the hypothalamus and the pituitary to turn down the TRH and TSH as if that were the body's thermostat. And how do we get from mostly T4 to T3? And I told you, well, this conversion happens with an enzyme. It's called the iodinase, and it removes the iodine to form T4, which is from T4 to make T3, which is the active form. And this is primarily done in the liver and the kidneys and the peripheral tissue. You should know that about T3 is about 4 times more potent than T4. It's the hormone that actually drives the metabolic activity. Thyroid hormone affects every cell and system in the body. So we always have to make sure we're not forgetting the thyroid. And depending on which influencer you're watching these days, your thyroid's in style and out of style. Oprah made it famous and everyone's talking about it ever since. So the thing to keep in mind is pattern recognition. I can't expect you to memorize all of these things. What I need you to do is to recognize patterns in the labs and patterns in the symptoms of the patients that you will be seeing. So for example, if T4 is low, but TSH is high, what does that tell you? What's the primary problem? T4 is low, TSH is high. What does that tell you? Well, what it should tell you is some reason somebody is yelling at the thyroid to make more, make more, make more, because it's not perceiving we have enough. This is the basic textbook definition of primary hypothyroidism. The thyroid gland is failing, and the pituitary is working overtime to crank out the TSH, and the thyroid's saying, meh, I don't feel like it. And so you have the net effect is a hypometabolic state. Now, if both T4 and TSH are low, what do we have here? Both are low. Well, if both are low, that means the failure to stimulate is the underlying cause here, right? And the failure to stimulate now is coming from a central source. So that's secondary hypothyroidism. The pituitary or the hypothalamus is not sending the right signal, so the thyroid is not getting stimulated. So that's secondary hypothyroidism. If both T4 and TSH are low, that is secondary. It means you're looking now for secondary causes. And if the T4 is high and the TSH is low, T4 is high, TSH is low, how do you explain that? Well, remember, the byproduct is the T4. That's the goal, right? So if that's the goal and it's high and TSH is low, that means we have a hyperthyroidism situation. The thyroid is overproducing and the pituitary is trying to shut down. It's practically whispering. It goes less than 1. It stops talking, and that thyroid is in overdrive pumping out the T4, right? And so the pituitary shuts down and the TSH through negative feedback, but it's not working. It's not shutting down. It's still going. Well, what can cause that? A whole host of things. We'll talk about it. But what if the T4 now is normal, but the TSH is abnormal? If T4 is normal and TSH is abnormal, well, if the T4 is normal with an elevated TSH, we call that subclinical. Subclinical hypothyroid. TSH is elevated, T4 is normal, subclinical. Also, if you have normal T4 and a suppressed TSH, that is subclinical hyperthyroidism. Okay, so the TSH is the thing that tells you if you're hypo or hyperthyroid. And then subclinical is determined by the value of the T4. Free T4, by the way, that's what we're measuring because it's only the free of anything that's metabolically active. Most of it is protein bound. Very good, Kira. Thank you for the subclinical. You could type your answers in the chat. Really appreciate that. So, okay. So what's the principal lab for interpretation when it comes to thyroid function? You always start with the TSH. That is the screening, if you will, for thyroid function. It's the most sensitive test because the pituitary reacts dramatically even to small changes in thyroid hormone level. Any questions so far about normal thyroid physiology? If you do, you can type them in the chat. If you feel bold, you can write them up in your hand and we'll talk to you. All right, so let's go on. So now we're going to talk about hypothyroidism. So what is the basic definition of hypothyroidism? I kind of gave this to you, so let's repeat. It's when the thyroid does not make enough T3 and T4, leading to slowed metabolic activity. And what's the most common cause worldwide of this situation? The most common cause, and primarily in the developing world, but the most common cause is iodine deficiency. In the developed world, the Western world, the most common cause of iodine in what we call iodine sufficient areas. That's the United States, where we required iodine to be put into the salt. Okay. And so people, I don't want too much iodine. You don't understand. You need to have this if you're not going to eat fish at least twice a week. So in order to make up for this, we mandated that iodine be put into the salt. And any salt that doesn't have iodine has to expressly be labeled iodine free. So keep that in mind. Hashimoto's thyroiditis is the most common cause of hypothyroidism in the iodinized world. Okay. And what is Hashimoto's thyroiditis? Well, it is an autoimmune disease where the immune system attacks and inflames the thyroid, gradually reducing the hormone output. The inflammation is making it insensate to the TSH, and so it's not pumping out. So how does the pituitary try to compensate in this case? Well, what do you expect it to do? Scream louder. So it's going to pump out more TSH. Make more, make more, make more, make more. And what happens is saying, no, I can't hear you. I can't hear you. I can't hear you. And nothing is coming out. So by ramping up TSH secretion to push out the thyroid harder, that's why we usually see the high TSH and low free T4. Okay, so what symptoms do you think you're going to have in this hypometabolic state? Oh, I'm so tired. I'm gaining weight. I'm too cold. My skin is dry. My hair is falling out. My heart rate is too slow. So when you have somebody that complains of any of these symptoms, what do you think the basic workup is going to involve? Well, let's check your TSH. First and foremost, let's check that TSH. Women of perimenopausal age, my hair is falling out, check the TSH. Why? Could be subclinical, but your manifestation is the hair falling out. And maybe you can't tell you're cold because you're in the middle of a vasomotor phenomena having a hot flash. So you can have two processes going on at the same time. But suffice it to say, someone has these vague, non-specific symptoms, TSH should be part of your primary investigation. Now, what else can cause this problem to occur? So in thyroid antibodies, can autoimmunity show up before you have full-blown hypothyroidism? Yes. There is a segment of the population that just has thyroid antibodies that are what we would call positive or, clinically significant, but the TSH-T4 is normal. The problem is a lot of things, just because you have the thyroid antibody, it does not mean we've begun the disease process. The body can still be compensating. I'm not sure what triggered that antibody to be released and formed, but you don't want to get premature and just jump on positive thyroid antibodies. This is why in psychiatry, when they start looking for red herrings, they say, oh, thyroid. No, it's fine. TSH is normal. No, do free T4 might be subclinical. We're really looking for any reason for this person to have this condition rather than for us to say they're depressed. And so we'll draw thyroid antibodies. No, don't do that because there's a population that has these elevated to begin with, and it doesn't clinically correlate. So the problem is people get overly ambitious chasing incidental findings, and we don't want to do that. So what you want to do is be very systematic in your approach to a diagnostic workup. Okay, so which antibodies are key in Hashimoto's? Well, you can have anti-thyroid peroxidase, which is anti-TPO, that's the test, what it's called, attacks the enzyme needed to make T3 and T4. So this antibody is attacking the enzyme that's needed to make T3 and T4. It's often linked with a genetic predisposition. So when you ask your patient about predisposing factors, when you take a history, did anyone in your family have an autoimmune condition? That's a genetic predisposing factor. But other things can set that thing off. Now, can you imagine being in a hospital setting? What might set off just a bump in those antibodies? Well, infection, stress, radiation if you're exposed, and excessive iodine, if you're taking supplements. So where the excessive iodine tends to come from in our day and age is someone sees an influencer and they swear they have the problem on Instagram, and then they start popping a supplement and they don't know what they have. The message I got this week in my psych practice is, what do you think of sea moss? Well, what do you think I think of sea moss? I think that you may as well throw your money in the toilet. However, what do I need to worry about with it? Well, if it comes out of the sea, it might have iodine in it. And I don't know what concentrations in there. And I don't know if you're going to inadvertently overdose on the iodine. So I gave the woman the warning. I said, might be helpful, won't be harmful. You just have to be careful about iodine because it can derange your thyroid, which can manifest and make your depression symptoms worse. Right? So just because it's natural and supplement and whatever, it doesn't mean it's necessarily benign. So just keep that in mind. That's where the excessive iodine would come from. The other antibody is the antithyroglobulin. Antithyroglobulin. This attacks the thyroglobulin, the protein precursor to the thyroid hormones. And this leads to chronic thyroid inflammation and progressive damage. So those are the key thyroid antibodies that you can draw. Those are so commonly done. They're always done together. Nobody ever just does one and not the other. You do them both together. Now, can I tell you the nuances and the specificity and sensitivity of each one? I cannot, and that's what I rely on my endocrine colleagues for. So the question then becomes, well, what is the long-term impact of these antibodies? Well, the theory is that there's chronic autoimmune attack. And to what degree, we don't know. So the question is, if you happen to find them elevated, it's not that you're going to do something about the elevated antibody per se right now, because whatever treatment you offer may also have adverse effects, and you have to be sure that the risk-benefit analysis checks out. But you're definitely going to monitor this person. Some will say 3 months, some will say 6 months, some will say at your annual physical, some will say follow up when you have symptoms, depending on who would say that. Suffice it to say, if you have positive thyroid antibodies, this may warrant an endocrine referral to get the blessing from them to say, you know what, watch and wait, nothing to do till symptoms develop, or in my world, this is what we're going to do, and they may proceed to give you more intensive follow-up. Chronic autoimmune attack, thyroid destruction, will eventually progressively reduce hormone production. So hypothyroidism is usually a lifelong condition, and it will require hormone replacement when that level happens. Now, I don't know the nuances of should we replace sooner than later? Does that reduce the work of the thyroid? Are we buying you some time? That's beyond my purview. My job is to just highlight to you how the thyroid can fail. When you work in a specialty area, though, you will then start to recognize how we can help it and what we can do. So what hallmark lab pattern of overt hypothyroidism would you expect to see? Type it in the chat since I've given you this twice before. What is the hallmark pattern of an overt hypothyroidism? Well, the answer is a high TSH and low free T4. The thyroid is failing. The pituitary is shouting. And what if the TSH is elevated, but the T4 is still normal? That's what we're calling subclinical hypothyroidism. The thyroid is struggling, but the pituitary stimulation is giving it all it's got, and it's keeping that T4 in range for now. So what does secondary hypothyroidism show? Well, in that case, you have both the TSH and the free T4 are low because the pituitary or the hypothalamus isn't sending the signals. And that's much less common, but now you know where to look. And so how do antibodies fit into the workup? If you see an elevated TSH with or without low T4, elevated TSH with or without low T4, you check the anti-TPO and anti-thyroglobulin antibodies. A positive result there points you to Hashimoto's autoimmune thyroiditis. And that is the underlying cause. So what is this take-home message here? TSH is the most sensitive screening test, but the antibodies will tell you the cause of why it's up or down. Elevated TSH plus positive antibodies equals Hashimoto's, even before symptoms fully develop. So let me say that again, because you may see that somewhere, I don't know, in a couple of weeks. Elevated TSH plus positive antibodies equals Hashimoto's, even before the symptom develops. Okay. So let's talk about this case here. Let's see what y'all put in the chat. Yes. Overt primary same. Okay. So look at this middle-aged woman with vague symptoms that are seemingly unrelated, right? Notice how the hypothyroidism can be the great masquerader. Patients often see multiple providers before they get a diagnosis. Now, they shouldn't, but the problem we run into in our subspecialized world, essentially, is if you are a specialist, that is to say a hammer, every problem that walks into your office tends to be a nail. And we don't want to do that. We want to say, are you the typical presentation for what comes into this office? And if not, we should go looking for other things that are not typically presented. So imagine this chief complaint you can see here: tired, weight gain, always cold. Tired, weight gain, always cold. Tired, weight gain, always cold. That's the classic triad for hypothyroidism. fatigue. And now why do these symptoms happen? Well, if you have fatigue, that's supposed to be due to decreased cellular metabolism and reduced ATP production. If you're having weight gain, that's due to the slowed metabolic rate and some fluid retention. Hang on to that fluid retention, because if it gets bad enough, that's what's causing the myxedema down the road. Cold intolerance because of the decreased thermogenesis and reduced cardiac output. So those are the reasons they're having the symptoms, due to this metabolic underproduction. So the timeline is about 6 months from insidious onset is typical. So, this is not today and tomorrow it's gone, unless of course you have surgery and we remove it overnight. But even then, there's a lag time to the residual hormones in the body. Patients tend to adapt gradually to this. And so what happens is, in addition to the gradual adaptation, they pick up some maladaptive behaviors. They may get depressed. They may get fatigued. They may get out of the habit of exercising. They may get out of the habit of doing a lot of things. And so then not only do you have this chronically maladaptively developed situation that's physiologically undergirded, but now you're going to have a psych component, whether you were looking for it or not. And because when you put the hormones on board, they're not going to be fixed tomorrow. So you have to realize there's a lot of anticipatory guidance that goes along with this, and you're going to have to offer some psychosocial support while they are acclimating to their new hormone levels. A big thing to pay attention to in this hypothyroid state is the strong genetic component. So always ask about thyroid disease in first-degree relatives. And the other major one that's often overlooked, because they like to blame it on everything else, and every social media person will tell you, oh, it's your gut biome, it's out of whack. Oh, you need more magnesium. Oh, the sun is not rising in the east for you. Whatever their reason is, constipation is often overlooked, but highly significant, because it reflects the reduced GI motility in somebody who is hypothyroid. Now, the classic picture is this demographic. It's the 42-year-old middle-aged female. Women are 8 times more likely to have hypothyroidism. Notice the bradycardia of 58. You could say, oh, she's a runner. No, she's not. She has no energy. And there's a direct effect of T3, T4 on cardiac conduction. Other things that you may notice, and this is why you want to do a whole physical exam when you see your patients, classic findings include the diminished DTRs. So an Achilles reflex, if you've not taken physical assessment, you can practice eliciting an Achilles reflex there. There's a prolonged relaxation phase, which means smack, and then it's a long delay before that reflex fires. Now imagine if you were one of these people popping extra magnesium to help the situation, making it worse and don't even know what's going on. Hypertension can happen in hypothyroid state. That's due to the increased peripheral resistance and fluid retention. So the hypertension is predominantly due to diastolic dysfunction. But it takes time for that to develop, because the body's really working hard to keep you alive and adapt and not have symptoms. The key pattern here is recognition. So you want to note that the individual symptoms are common, but it's the constellation that makes this the diagnostic picture. So always think thyroid when you see unexplained fatigue, cold intolerance, weight gain, family history, and compatible physical findings with multiple seemingly unrelated symptoms. Now, in psychiatry, we say if someone comes in with a whole bunch of unrelated symptoms and they have followed that systematic approach, then we say think of anxiety. But part of that systematic approach is the step 3 that says rule out an underlying medical condition, which could be thyroid disease. So take a note of how depression is listed as well as fibromyalgia here. This is crucial because hypothyroidism can mimic these psychiatric and rheumatologic conditions. So always check the TSH before diagnosing somebody with depression, especially in women over 40. No SSRI in the world is going to help this situation. Okay, not even Ritalin going to help this situation. So trust the clinical picture, but always confirm with labs. This patient presentation strongly suggests a primary hypothyroid state and likely Hashimoto's given the family history of and the goiter. There's a family history of thyroid disorder. Does this mean you are at greater risk? Yes. Which thyroid disorder? Yes, that's why we put that in there. That's why we're asking about the family history. Yes, family history is a component here. I can't tell you a single gene that's doing it, but there tends to be this hereditary correlation. Hypothyroidism workup. So how will you diagnose this condition? What was the single best first-line test for suspected hypothyroidism? TSH. It's the most sensitive because the pituitary reacts logarithmically to small changes. That means the slightest bit change in TSH, that pituitary pick it up like that, and it doesn't cause more releasing hormone. So what TSH levels raise concern? Esmira, yes, you have a question?
Yes, good afternoon, Dr. Zachary. You mentioned something about having hypothyroidism, but being in the perimenopausal
We'll get to that. Yes, so you can because of when it happens to middle age. So you can be perimenopausal and also have hypothyroidism. The problem is because of your age, you may be prematurely judged to be labeled perimenopausal, and no one will go looking for this. So the reason I bring it up is to make sure that you do not stop being systematic in your evaluation. Don't just assume because the person is in perimenopause, therefore it's perimenopause without investigating. A lot of women get written off. And so you want to give careful attention. Don't just assume.
Thank you so much.
Mm-hmm. So what TSH level raises concern? The concern is raised here because of the greater than 10 international units of TSH. If you're greater than 10, that's like overt hypothyroidism, and it's going to need treatment. If you're in the 4.5 to 10 range of TSH, that likely will fall into the subclinical hypothyroid realm, and the free T4 can likely still be normal. Now, can you have a deranged T4 at less than 10? Yes, but in general, 4.5 to 10 TSH is going to put you in the subclinical range. Now, you have the option to order TSH and free T4 at the same time. Most labs also have the option to do what they call a reflex test. I like reflex tests because we don't waste a lot of time and money. But basically what the reflex test does is it tells the lab if the TSH is abnormally high, meaning outside the range, go ahead and do the free T4 so that you don't have to come back, separately reorder, poke the patient again, etc. So you can do a TSH with a reflex T4, free T4. So why do we measure free T4 instead of total T4? Well, I just told you, the free T4 reflects what's active, unbound hormone. It's not distorted by binding proteins, and it tends to correlate better with symptoms. Same for when you get to my psychopharm class. It's the free drug levels we're interested in. That's what we're worried about. Also, that's why looking at overall nutrition status, protein intake is a major factor. They suddenly start starving, they may have a whole lot of free active drug or free active hormone in their system, so you just have to be careful about that. So that's a sidebar. What systemic labs can hint at hypothyroidism beyond TSH and free T4? Well, some systemic labs, some routine labs that you may see, and this is important, hyponatremia. Hyponatremia is the most common electrolyte derangement in a hospitalized patient. So many things can cause it. You would hate to miss hypothyroid as being one of the things causing it because of the water retention, okay? It's dilutional. So you don't want to miss it. Hyponatremia, impaired water clearance. The other thing is an elevated creatinine. Why? Due to the reduced GFR. The water's not going through the kidneys. The other thing is hypercholesterolemia. When someone has hypercholesterolemia, you should say, why do you have this? Rather than blaming the Big Mac and the hot dogs, you need to say, well, do you also have hypothyroid? And so we're not clearing it. There's fewer LDL receptors. So those are three other general lab conditions that should raise your index of suspicion to say, hey, let me go work up that thyroid while we're at it. Okay. Now, if TSH and free T4 confirm hypothyroidism, why might we check the antibodies? Well, TPO antibodies are positive in about 90% of Hashimoto cases. They identify an autoimmune cause that helps to predict progression of disease, especially important in young patients. So, we want this in middle age. If you're a young person that's having this, now we're really thinking autoimmunity. And so that anti-TPO antibody is positive in about 90%, especially in young patients and those with a family history of autoimmunity. Now, what about the lipid panel? Well, the lipid panel is part of the workup because hypothyroidism often causes secondary dyslipidemia. Now, you got to treat the thyroid first before starting a statin. Cholesterol will often improve once the thyroid levels are normalized. So the classic pattern for primary hypothyroidism, high TSH, low free T4, that's the signature of a failing thyroid. And how does the central secondary hypothyroid look different? Central secondary hypothyroidism is different because you have a low or normal TSH and a low free T4. And here, the pituitary or the hypothalamus is the problem, not the thyroid. So what's the clinical pearl you need to take home? TSH is not linear. Very small TSH changes. A TSH of 15 isn't twice as bad, say, as hypothyroid as a 7.5. Small changes in T4 cause big jumps in the TSH. So when do we do additional testing? You do additional testing beyond TSH and free T4 in young patients. Think anti-TPO antibodies. Goiter, if they have a goiter, consider a thyroid ultrasound. And if the symptoms don't match the lab work, then you need to think about central hypothyroidism, and maybe you'll order an MRI of the head looking at the pituitary to see if there's something going on there, an adenoma or something like that. Okay. So take a look at this, hypothyroidism treatment. If the thyroid can't make enough T4 and T3, what's the solution? What do we do for these people? Well, these are the people that we replace it, right? We replace what's missing. Levothyroxine for these people. And why give T4 and not T3 directly? Why do you think we might do that? Well, T4 has a long half-life, about 7 days, and the body naturally converts T4 to T3 using that enzyme deiodinase. Well, this gives a stable level. When we're talking about drugs that we want a steady state for easily without a lot of variation, if they miss it one day or, whatever, there's a long half-life that buys you some grace. In general, though, you want to give the levothyroxine on an empty stomach first thing in the day. If you can't do first thing in the day, maybe they don't eat 2 hours before bedtime, the stomach is empty, they could take it at bedtime. I don't care when they take it, but the stomach should be empty and not with other meds. And now, if you've worked in healthcare long enough, you know that we give ourselves an hour grace on either side of that drug pass window. We pour all the pills in one cup and say, God bless and swallow, right? And we do that for a week, 2 weeks, 3 weeks, a month. And if it's going down the NG tube, it's all getting crushed up and down the tube it goes and bound up to the calcium you just gave them. And they're not getting thyroid hormone and away we go. Oh, you're getting iron supplement with thyroid. There you go. You're not getting anything now. There you go. Throw it all in the toilet. So it kind of matters. I know that in reality, it doesn't happen. It should happen. When you're prescribing it, you're going to say, please give on an empty stomach when you write that prescription. At the end, we're in the Lord's hands. Okay, so how do we know that the treatment is working? Well, adequate replacement will restore the negative feedback system. So as the T4 normalizes, the TSH level should start to come back down within the normal range. And your goal is to normalize the TSH, not the free T4. Okay, you're targeting TSH with your treatment. And what's the target for TSH for most adults? It's about 0.4 to 4. Some guidelines recommend somewhere between 1 and 3. In general, people feel really good with a TSH of 1. By the time they get to a TSH of 1, all of their symptoms should be gone, but it takes time to get there. So how do you dose this? Well, in your pharm class, you'll learn this, but I'll just give you the general guidelines here. You don't need to hang on to this forever. I'm not going to ask you doses on the test, but in general, healthy adult, about 1.6 to 1.8 micrograms per kilogram per day. So you look at what's available, though, and you're going to do a little rounding because we're not going to break little tiny pills in half. Elderly or cardiac disease, you start low. And when I say start low, they do this arbitrary start of just 25 or 50 micrograms, and then they titrate slowly. Slowly means about every 6 weeks. That's what slowly means. Now, there is a special carve out here for pregnancy. Pregnancy may need, meaning someone with hypothyroid that happens to get pregnant that has been already on levothyroxine, they may need about a 30 to 50% dose increase because of the increased clearance, right? They have more volume in the body. The monitoring strategies, you're going to check that TSH about every 6 to 8 weeks after a dose change because you want to allow enough time for steady state. And so I'll bring you this little tip from pharmacology. When is steady state reached? After 5 to 6 half-lives. What's the half-life of this levothyroxine? 1 week. So 5 to 6 half-lives to steady state. That's why 5 to 6 weeks after you titrate the dose, you're going to go check the level at that point. That's also when you're going to call it a washout period, 5 to 6 half-lives to get it completely out of the system if you're going to stop the drug. Now, once stable, you can go to yearly monitoring. Now, what about central hypothyroidism? Let's see if this question is here. Yes, synthroid. Very good. Thank you. What about central hypothyroidism? So TSH is an unreliable value when you're dealing with central hypothyroidism. Instead, this is who you're aiming the free T4 for. You're looking for that free T4 to be in the upper normal range, because pituitary failure means that the TSH is not really reflecting thyroid status. Remember, it's the pituitary has failed. So what common medications would interfere with the levothyroxine absorption? Remember how I said we need to separate it? Well, if you're giving iron, calcium, or coffee, morning coffee, 3 to 4 hours. PPIs can increase the dose requirement as well. So if they're on a PPI, they're going to need a higher dose. And also, interestingly enough, estrogen therapy. So how many of the women are taking oral contraception that contains estrogen and happen to also be on levothyroxine? That raises the thyroid binding globulin, so you might need a higher dose. Why that matters? Suppose they start the birth control after you've put them on the levothyroxine. And you're like, we were stable. What's going on? That's why you need to ask at every visit. Since you've last seen me, have you seen any other providers, taken any other medications, been to the emergency room, the urgent care? Did you take any treatment for yeast infections? Are you taking anything once a week or once a month? Why? Because they will forget that they are taking anything if it's a once a week or once a month. And when they see you, they feel fine and they forget to tell you. So medication reconciliation is always very important. Now let's talk about this big problem here. Pregnancy and hypothyroidism. Why is hypothyroidism dangerous in pregnancy? So we need to be treated because it raises risks for both the mother and the fetus. For the mother, it can set the stage for preeclampsia, placenta abruptio, and hemorrhage. And for the fetus, it increases the risk of miscarriage due to placental insufficiency, prematurity, impaired brain development. Those babies are not going to develop well in a hypothyroid state. And mind you, they are very dependent on mom's thyroid for the first trimester. The most critical trimester in fetal brain development is the first trimester. The fetus relies entirely on the maternal T4 until about 12 weeks. So deficiencies here can cause permanent neurological damage. Now, the TSH goals during pregnancy, for the first trimester, you're aiming for less than 2.5. You want a TSH of less than 2.5. Second or third trimester, you can go down to less than 3 if you want to liberalize a bit, but less than 2.5 is preferred in pregnancy. So what happened to the levothyroxine dosing, say, once a woman becomes pregnant? Well, if she becomes pregnant, she might need that increased dose of 25 to 50% more early in pregnancy. And what you're going to do here, when you're doing the antenatal care and checks, you're going to recheck that TSH level about every 4 to 6 weeks and adjust the dose as needed. So why can HCG affect thyroid labs in early pregnancy? Well, HCG weakly stimulates the TSH receptor. So in the first trimester, you may see the highest HCG levels. That can cause mild TSH suppression, right? Because we don't need two things stimulating. So if the HCG is doing it, then the TSH will come down because of that negative feedback system. And this is a normal, and it's not always pathological, so don't get too upset if you see that happen. So how would you then distinguish HCG-mediated thyrotoxicosis, say, from something like Graves' disease? Well, gestational thyrotoxicosis is generally mild. It's transient. There are no antibodies. No antibodies is a big one. And it resolves as the HCG level falls. That's gestational thyrotoxicosis. That's just, it's going to resolve. Graves' disease, on the other hand, is an autoimmune condition. You'll have a positive TSH receptor antibody. You might see a goiter, and you might see ophthalmological manifestations. And by the way, Graves' disease requires treatment. Gestational thyrotoxicosis doesn't need treatment. So your goal in hypothyroidism treatment is to replace the T4, monitor the TSH. If it's central disease, then you're treating to the mid to upper range of the free T4. Titrate carefully in pregnancy and treat aggressively. I'd rather you overtreat mom a little bit rather than undertreat her, because that will protect fetal health down the road. Obviously, you're going to do this in concert with OBGYN. Okay. All right. Now, that was hypothyroid. Here we go to hyperthyroidism. So hyperthyroid disorder, what is this? Well, the name says it all. Too much of a good thing. Hyperthyroidism is the mirror image of what we just talked about. Too much thyroid hormone action at the usual tissue level, and the body's engine is revving high. This is like pressing the gas and the brake at the same time, and that engine is revving. So what happens to the metabolism when the thyroid hormone is in excess? Well, that's the metabolic accelerator. So you're going to have all those opposite symptoms: increased heat production, weight loss despite increased appetite, and faster GI transit. You're running to the bathroom. Now, people will do secondary gain and lie. People will come to psychiatry and lie, and to their primary too, about having hypothyroid symptoms because they read somewhere online that if you give them thyroid hormone, it's going to raise their metabolism and make them skinny. And so they will lie to you to get levothyroxine. So that's why you got to do the workup. So why do patients look anxious and sweating and tachycardic when they have hyperthyroid for real? It's because thyroid hormones amplify the sympathetic nervous system. So it looks like too much anxiety and stimulant use. Now, something to pay attention to is if they've looked relatively normal and stable and they're on levothyroxine and now they suddenly look high, couple of things. Either they've started to neglect themselves, and I see this in my elderly, or they forget they took their med and they take it again, and they inadvertently start overdosing themselves on their levothyroxine. So pay attention to that when you do your medication reconciliation. Ask broader questions. And the hallmark lab finding, by the way, in hyperthyroid, well, if TSH was high in hypo, it's going to be low in hyper. And this is what confuses everybody, right? So ask yourself, what is it you're testing? Thyroid stimulating hormone. We stimulate the thyroid to make more. The more I stimulate, the more I make. That means TSH is high, it's hypothyroid. If I'm not stimulating, it's low. I'm not stimulating because I'm making enough. So a suppressed TSH with elevated free T4 or T3, that is your lab picture. Low TSH, high T4. And there you go. Subclinical is diagnosed when the TSH is suppressed, but the free T4 remains normal. Right? TSH is down, free T4 is normal. That's the subclinical version of hyperthyroid. It still matters because it's still increased risk for things like atrial fibrillation and bone loss. You realize the metabolism is still going in overdrive. So one of the differentials, if your patient suddenly goes into atrial fibrillation and you don't know why, there's a reason. We got to check that thyroid. Don't forget, whenever you have a patient present, you got to make sure that the thyroid is not deranged and driving that maladaptive condition. So what is the most common cause of hyperthyroidism? Well, in about 70 to 80% of the population, it's Graves' disease. And what is Graves' disease? Well, there are autoantibodies. Thyroid stimulating can mimic TSH. So this is the driving diffuse gland stimulator. So TSI can be mimicking TSH and it's pumping it out. Now it could be, this is an ectopic focus usually. So what clinical clues point to Graves? Well, things like a goiter, ophthalmopathy, so the eye bulging situation. If the eyes are bulging, they get that exophthalmic lobe. They may have diplopia, family history of autoimmunity. Other things can be things like a toxic nodular disease, so like an autonomous nodule, an ectopic nodule on the thyroid, say, can make hormones on its own. It's just pumping out hormones without TSH telling it to do anything. In fact, it's not even listening to the TSH, it's just doing its own thing. Typically seen in older patients, it's a gradual onset, and in a toxic nodular disease state, you typically do not get the eye symptoms. You just have a nodule, you can feel it, and the hormone levels are abnormal. And then there's another condition called thyroiditis. Now, this is not overproduction of a hormone per se, but it's leaking of damaged cells from an inflamed gland. This is often transient. This is your patient who in the hospital seemed fine and a good resident did the TSH and, oh, did you know you have hyperthyroid disease? No. Okay, maybe you don't. What do you mean? Well, stress and inflammation can cause that thyroid cell to get damaged and leak out whatever's in there. So you may have an incidental low TSH. And I don't know when the stress happened to you, but something caused you to come to the hospital. So we don't jump on that right away. It's not an overproduction in thyroiditis. It's hormone leakage from an inflamed gland. Often transient. Sometimes it does progress to hypothyroidism. If the gland is painful, so when you do your physical and you have tenderness over the gland, you might want to think about subacute thyroiditis. Now, the question is, how do you tell this all apart? Well, how do you distinguish, say, hyperthyroidism from an anxiety disorder? Right? Because it looks the same. Anxiety doesn't cause weight loss with increased appetite. Weight loss with increased appetite. Weight loss with increased appetite should make you think about a hyperthyroid picture. The other thing is a spontaneous atrial fibrillation. That too should make you think I should investigate this a little further. The other thing is, we live in an age of pills and diversions, so you need to think about stimulant use. So check the patient's drug history, maybe a toxicology, outright ask them. But the stimulant intake will not give someone a goiter, and it won't give them eye changes, and it won't suppress the TSH. So that's why that's worth asking the question. So there is an emergency that you must not miss here. Do not miss this thyroid emergency. And the thyroid emergency you don't want to miss is thyroid storm. Okay, thyroid storm comes with a cluster of symptoms, namely fever, altered mental status, and cardiovascular collapse. This is an ICU patient all of a sudden. If you have new atrial fibrillation in older adults or a rapid weight loss of greater than 10% body weight in 3 months, all of that should make you say, oh, red flag, hyperthyroid. I need to look and not miss it. So what causes this hyperthyroid situation? You can have Graves' disease. You need anti-thyroid drugs for that, like methimazole. Or definitive therapy. Definitive therapy is always surgery. Remove it. Toxic nodules usually requires radioiodine or surgery. They just remove the nodule, not the whole thyroid. And ideally, if you don't have to do a total thyroidectomy, you want to avoid that. Otherwise, you are really putting this person on meds for life. So if subtotal is sufficient, it's not a bad way to go. Some people say, I don't ever want to have this again. A longer discussion than what we need to have here. And then thyroiditis is often really, it just needs some supportive care, maybe some beta blockers if they're having a relative tachycardia, but generally it will resolve itself. You just supportive care for them. The bottom line of all this is hyperthyroidism is the great accelerator. Everything speeds up. Diagnosis depends on labs, but the treatment depends on the cause. So always ask Graves, toxic nodular disease, or thyroiditis. All right, take a look at this, this slide here with this case presentation. What we have is a hyperthyroid paradox. So you have weight loss despite eating more. Remember that, weight loss despite eating more. Well, this is the classic paradox that should immediately make you think thyroid. Increased appetite plus weight loss, accelerated metabolism. This is not puberty, by the way. Anxiety and a jittery feeling, that's the sympathetic overdrive from excess thyroid hormone. So there's an increased metabolic rate of about 15 to 20% for every 50% increase in hormone level. And the key red flag here is this classic demographic of a 35-year-old female. Women are 5 to 10 times more likely than men to have hyperthyroidism. The other thing to pay attention to in hyperthyroidism is this rapid timeline onset. Unlike hypothyroidism, hyperthyroidism often will present acutely. So that's another thing to pay attention to. Heat intolerance, patients will go around turning down thermostats, removing blankets. They prefer cold weather. They may complain of palpitations and insomnia. That's due to the direct cardiac effects. So always check for atrial fibrillation. That means this person is getting an EKG. If they report palpitations and they're not going on in the office, you might need to do an event monitor with this person or a Holter or something. Physical exam for Graves' disease, specifically here, you're going to look for vital signs. Systolic hypertension is often due to the increased cardiac output, due to the increased metabolic rate, due to the increased heart rate. That's 102 here. Anything greater than 100 in a young person warrants a TSH check. So if you're in the office, you sit, you breathe, you relax, and that heart rate is still over 100 at rest, we need to check the TSH. And also an EKG, because you want to make sure it's normal sinus or sinus tach. And so exophthalmos, this is the pathognomonic finding for Graves' disease. This is caused by TSI affecting the orbital tissue. And also a diffuse goiter. This is a smooth, symmetric enlargement. It's different than nodular disease. And also you might notice some hypermetabolic symptoms. You may see a fine tremor if the patient extends their hands. The best way I say to do a tremor is you take a piece of paper, right? I do this for my alcohol withdrawal. Do you have a tremor? Hold out your hand. They say no, right? So then I take a piece of paper and put it here. Do you have a tremor? And does the paper move? And if the paper moves, then you can easily see the tremor and even count the oscillations if you're so inclined. But suffice it to say, that's a good way to check someone for a tremor. Hyperreflexia. So you remember the other one had long DTRs. This one had very brisk DTRs throughout, which is the opposite of hypothyroid. This patient situation here points to Graves' disease for these reasons. Only seen in Graves' disease, exophthalmos, diffuse goiter. Toxic nodular disease would have a palpable nodule. Young female, peaks in the 20s to 40s. Toxic nodular disease is typically seen in older patients. The differentials always need to be considered and ruled out just because, you know, they present. So your differentials always include anxiety disorder, stimulant abuse, toxic nodular disease, thyroiditis. The red flags you don't want to miss in this case would be the hypertension in a young person. Don't misdiagnose this person as early onset hypertension when you've neglected to look at the thyroid, and all you do is you put them on blood pressure medicine and you're forgetting that underlying cause. It could indicate a thyroid storm. Tachycardia and anxiety, you got to monitor for cardiovascular complications and always try to clinically correlate the pathophysiology that the patient is demonstrating. So excess T3, T4 affects every organ in the body. Now, let me just give you a little bit on pregnancy here. So hyperthyroidism in pregnancy is defined by a low TSH and elevated T4 or T3 levels. And that affects about 0.1 to 0.4% of pregnancies, with Graves' disease accounting for about 95% of cases. The autoimmune condition involves stimulating antibodies that overstimulate the thyroid gland, leading to excessive hormone production. Pregnancy can exacerbate hyperthyroidism due to the immune system's modulation of hormonal changes, but it's distinguished from gestational transient thyrotoxicosis, which is self-limiting, and that condition is governed by the HCG level in the first trimester. So the diagnosis obviously relies on labs. Thyroid stimulating immunoglobulin, TSI, thyroid stimulating immunoglobulin, also known as TRAB. This level is what you're looking for to make this diagnosis. Clinical signs like the goiter and ophthalmopathy, pathological eyes, is what you'll also see. So untreated, this poses risk to mom and baby, and this can necessitate the rapid administration of anti-thyroid drugs. And beta blockers are essentially there to just buy you time for symptomatic control. You are definitely having OB involved in this case, and definitely having endocrine involved in this case. So you should know that thyroid stimulating immunoglobulin can cross the placental membrane. And Graves' disease is the leading cause of hyperthyroidism in pregnancy, and it often presents or worsens within the first trimester. And the maternal risks are the same as I've given you before for hyperthyroidism or thyroid storm, but preeclampsia and placental insufficiency. Fetal risks include intrauterine growth restriction, premature labor, and fetal thyrotoxicosis. So then at delivery, you'll have problems there as well. The intrauterine growth retardation is about 20 to 30% if left untreated. And the reason that happens is that increased blood pressure leads to vasoconstriction, which reduces blood flow to the fetus. Premature labor before 37 weeks happens in about 20% of people with hyperthyroidism from uterine hyperactivity. About 5% will have fetal tachycardia, that is a fetal heartbeat of greater than 160. Treatment, PTU is preferred in the first trimester because of lower, not no, lower teratogenic risk than methimazole. Antithyroid drugs are the first-line treatment. Obviously, you need to give them given the complications that may develop. So this is going to be a very challenging time for mom because she's going to decide, oh my God, if I don't treat this, I have all these complications. And if I do treat this, the risk of teratogenicity is not zero. So what you're trying to do is block the thyroid hormone synthesis while allowing for fetal hormone needs via placental transfer. And the same monitoring happens here, TSH-free T4, but also at this point, TSI, thyroid stimulating immunoglobulin. All right. So let's talk about hyperthyroidism workup. So where do we always begin the hyperthyroidism workup? We begin with TSH. It's the most sensitive screening tool. A suppressed TSH of less than 0.1, that's the hallmark of hyperthyroidism. So why does TSH suppression matter so much? Because of the logarithmic relationship. A small rise in T4, T3 causes dramatic drops in TSH. That's why the TSH of less than 0.1 has a 95% sensitivity for overt disease. Once the TSH is suppressed, what is it that confirms the diagnosis? Free T4 and free T3. Free T4 is elevated in most cases, but free T3 is often more sensitive. That's why they'll draw that one. Some patients present with T3 toxicosis, which is essentially just an elevated free T3 and a normal free T4. So something is happening in the conversion there. They're converting a lot more. And why do we measure the free hormones instead of the total? Because it's the free that is metabolically active. Good. Now, how do we determine the cause of hyperthyroidism? We use thyroid stimulating immunoglobulin. That's the test. How do we determine the cause of hyperthyroidism? So that means you do the TSH, it's low. Your next test is the thyroid stimulating immunoglobulin. And that's what confirms Graves' disease. You can also do a radioiodine uptake scan. It's a nuclear test. It comes with nuclear precautions. People will be resistant to this. If the TSI is negative or the nodule is suspected, that's why we do the radioiodine reuptake test. TSI is just easier to do. It's a blood test. Radioiodine uptake is more complicated. It's the older test, but if you can get the answer from the TSI, you don't have to proceed to the radioiodine uptake. So you should order TSI on a young patient with diffuse goiter or ophthalmologic findings. That's when Graves will be most likely. You should also order it on pregnant women because TSI can cross the placenta. When planning long-term therapy, since the treatment choice differs for Graves versus nodule versus thyroiditis, those are the three criteria for ordering thyroid stimulating immunoglobulin. So what will you see on your test? If you do the radioactive iodine reuptake scan, you're going to see a high uptake in Graves' disease. You may see what they call focal uptake just in that toxic nodular disease, meaning that one area of concern will have the uptake. Or you'll have low uptake because it's not related and it's thyroiditis, meaning it's due to hormone leak and not overproduction. So that's how you deal with the radioactive iodine uptake scan. High uptake Graves, focal uptake toxic, low uptake thyroiditis. What other labs might be helpful? Remember I told you there were some other labs talked about the sodium and the creatinine and the like. Well, some other labs can be helpful here in hyperthyroid. The CBC is helpful. You might notice a mild anemia or a mild leukopenia. That's common in, or watch for agranulocytosis starting when you give antithyroid drugs because you may suppress too much. The other thing in the CMP, the comprehensive metabolic panel, you might see hypercalcemia due to bone turnover. Or you also might see elevated alkaline phosphate. Alk-phos is released from bone. And you also may see hyperglycemia. Those are some labs that you would indicate, oh, why would you have that? What's putting this metabolism in overdrive? Hyperglycemia, let me go look further. Don't just blame your patient as being diabetic or pre-diabetic because they or impaired glucose tolerance because you have hyperglycemia. You got to look a little further. So there are some diagnostic patterns you should pay attention to. The classic overt hypothyroidism pattern: suppressed TSH, elevated free T4 and or T3. The subclinical version of this is suppressed TSH, normal T4, T3. Still clinically important, especially for AFib and osteoporosis, because it's speeding the metabolism. That means you're breaking down the bone faster. Suppressed TSH with normal free T4 and an elevated T3, that's your thyrotoxicosis. T3 toxicosis, suppressed TSH, normal T4, elevated T3. Often it can be early Graves or just nodular disease. Your investigation will tell. So how does pregnancy complicate this workup? Well, pregnancy complicates it because TSI testing is preferred in pregnancy because we don't want to expose them to radiation while they're pregnant. HCG can physiologically suppress TSH in the first trimester, so we don't want to overdiagnose. So what we're saying is pregnancy brings special circumstances. You need to interpret your results differently. Also, untreated hyperthyroidism in pregnancy risks preeclampsia, miscarriage, and growth restriction. Now, what about postpartum women with thyroid symptoms? Now, you may see these, whether you might not do antepartum, but you were more likely to get postpartum. Well, always consider postpartum thyroiditis because it has hyperthyroid phase and symptoms, meaning anxiety, palpitations, weight loss. Now, in the postpartum period, all of this symptoms, anxiety, palpitations, weight loss, can be caused by the fact that you're a new mom all of a sudden. And all of a sudden, you're not sleeping, you're sleep deprived, you don't even think you want to eat straight, and so you're nervous that someone's going to lose the baby. All of these symptoms can come up with that, but you can't still forget about postpartum thyroiditis. Often it swings into a hypothyroid state, which gets mistaken as postpartum blues because they have fatigue and depression. The problem is you're going to say, oh, you're sleep deprived. You're a good mom. Don't worry. They're there. Psychosocial support. You forgot to look for hypothyroidism in the postpartum period. So in postpartum, the thyroid can be affected. Earlier, thyroiditis, elevated, hyperthyroid. Later, hypothyroid postpartum. So a good postpartum follow-up at your 4 or 6 week should include a TSH. Okay. So here are some red flags. If you have a very high T3, that's like a red flag for a thyroid storm. If you have new atrial fibrillation in the elderly, red flag. Pregnancy with severe hyperthyroidism, red flag. Persistent symptoms more than 6 months postpartum, likely Graves' disease, and it's not transient. They don't tell them it's because they didn't sleep train their baby. Please do due diligence and work up the situation. So what's the systematic approach? You confirm the diagnosis with TSH and free T4. Determine the cause with thyroid stimulating immunoglobulin. or radioactive iodine uptake. Then you tailor the treatment to Graves' disease, nodules, or thyroiditis. Okay, so once you confirm hyperthyroidism, what's the next step? You need to determine the cause, because Graves', nodules, and thyroiditis require completely different treatments. Radioactive iodine uptake, that's the gold standard for identifying the cause, but we try to avoid it if we can because of the radiation exposure and the lifestyle complications for the next couple of days. But radioactive iodine is the thing that will distinguish between overproduction versus hormone leak. What does high uptake more than 25% mean? That means Graves' disease. Focal uptake is toxic nodular, no uptake, thyroiditis. Low uptake, less than 5%, thyroiditis. Oh, the other thing is you'll have low uptake. This person will also be the one that inadvertently started taking too much thyroid hormone. So we call that factitious thyrotoxicosis. It's not that, so it's factitious because factitious means a person wants to be in the sick role. It's not that they're trying to play on you. Some people, you know, cognitive impairment can say, oh, I forgot to take my medicine. I took an extra one. I didn't take an extra one. I don't remember if I took it again. And you'll find people like that because they're deathly afraid not to take it. Suffice it to say, patients taking thyroid hormone pills, the gland goes cold and, you know, there you go. Also, iodine-induced hyperthyroidism. That's a problem if they're on some sort of health supplement that they're not telling you about, or they don't think is significant. Focal uptake means the nodule, just the nodule is reuptaking that. That's what that means, focal uptake, radioactive iodine uptake. So what's replacing radioactive iodine uptake in most cases is the thyroid-stimulating immunoglobulin antibody testing. It's safer in pregnancy, rapid turnaround, severity correlates with level. And when do you do a thyroid ultrasound? Well, you do reach for ultrasound in hyperthyroidism when there's a palpable nodule, the gland is asymmetrical, or when you're planning surgery. And what does it show in things like, say, Graves' disease? That's when you're going to see diffuse enlargement, smooth texture, and something called a thyroid inferno on Doppler. That means increased flow. And what does this show in a toxic nodular goiter? You'll see a discrete nodule, heterogeneous texture of the thyroid, and peripheral vascularity around the nodule. All right. Let me ask you some questions. When do you order TSI instead of radioactive iodine uptake? And when is radioactive iodine uptake still the best choice? And what is the classic RAI reuptake pattern? What does Graves do? What does toxic adenoma do? What does multinodular goiter do? What about thyroiditis? Type in your answers. So hyperthyroidism, red flags. When should we worry about red flags in hyperthyroidism? When the disease extends just beyond the elevated hormones into things that yield airway compromise, eye disease, or risk to pregnancy. That really is what drives the urgency of hyperthyroidism. And what the elevated TSI level means is it's signaling some sort of aggressive autoimmune activity, and it's increasing the risk of a thyroid storm. What a large goiter matters is because it can have compressive symptoms, compressed airway, compressed vessels. You may hear in your exam dysphagia, a little stridor, they're breathing a little louder. Something is getting in the way of that airway. Don't just jump on the bandwagon and say obstructive sleep apnea, go get a sleep study, loose fatness in your neck. No, examine the neck, draw the labs, do the ultrasound. Even if the hyperthyroidism in states, you always have to rule out malignancy. Don't assume everything is benign just because the gland is overactive. So you do have to rule out malignancy. And the ultrasound will raise your index of suspicion to refer to the endocrine for the fine needle aspiration in order to make that diagnosis. TSI does cross the placenta, so the fetus may develop fetal thyrotoxicosis. So what is it that causes the exophthalmia or the proptosis in Graves' disease? Well, it's the same antibody that's overstimulating the thyroid, but now it's just attacking the tissues behind the eye. And the autoimmune target is the TSH receptor antibody, and that binds to the orbital fibroblasts, which also expresses the receptor. So what happens next? Well, remember that inflammatory cascade we did in week 1? That inflammatory cascade, the cytokines like IFN, TNF, IL-1, they activate the fibroblasts. And so you're getting this inflammatory response in the tissue behind the eyes, causing a glycoaminoglycans, that is, water-binding molecules are swelling behind the orbital muscle and fat. And then what you see is a protuberant eye. It pops out of the bony socket, essentially, and the pressure is what's pushing the eye forward. Graves' ophthalmopathy is an autoimmune-driven, not simply a function of excessive hormone. So we have medicines for that now. Ophthalmology generally treats it, but rheumatology may also do that. Okay. So what's the treatment for hyperthyroidism? Well, the core goal is treating hyperthyroidism. You want to, number 1, inhibit the excess thyroid hormone synthesis release. Number 2, you want to control the hyperadrenergic symptoms. And number 3, you want to reduce that overactive thyroid tissue if it's autonomous, meaning it's a nodule doing the work, or restore normal hypothalamic pituitary thyroid axis. So how do you manage the hyperadrenergic storm, the palpitations, the tremors, the anxiety? You manage that with the beta blockers, propranolol, indirol, atenolol. That's the front line. And then beta blockers, though, don't treat the cause. They're only treating the symptoms. So what's happening in Graves' disease is the TSH receptor antibodies, thyroid-stimulating immunoglobulin, mimics TSH, and that makes the whole gland overproduce hormones. So the first-line therapy for these people is going to be antithyroid drugs like methimazole or PTU to block hormone synthesis. Well, what if the patient's pregnant? Well, then PTU in the first trimester is what's preferred due to the lower teratogenicity. Toxic nodular goiter treatment, like a toxic adenoma, that means that one or more nodules is producing hormones autonomously, ignoring the stimulation hormone, right? The gland has had an ectopic production. And antithyroid drugs will not work long-term because the tissue is not responding to stimulation. It's just doing its own thing. So the definitive treatment is radioactive iodine ablation or surgery to remove the overactive nodule. If you're dealing with thyroiditis, subacute, silent, postpartum, this is different than Graves' disease or nodular disease. It's not new hormone production. It's release of pre-formed hormone from damaged tissue. And what the radioactive iodine scan will show here is a low or absent uptake. Jake, you need to stop falling out of the class. Low or absent uptake. The gland isn't actively making hormone. So what do we treat here? Nothing. You're just doing supportive only. So usually beta blockers for symptoms, antithyroid drugs don't have a role to play here. And then if you're doing thyroid storm, this is the emergency. It's an extreme life-threatening exaggeration of hyperthyroidism. So you have to think of this as the body is in complete metabolic overdrive. They're going to need a lot of support for this. It presents with fever, tachycardia, maybe atrial fibrillation, CNS agitation, delirium, can have coma even. This is very different than ordinary hyperthyroidism because it's very destabilizing and can lead to death, essentially. The mortality rate untreated in a thyroid storm is about 30%. So that's quite high. So the reason it happens is it's usually some sort of stressor can trigger it. So you might notice this in a subtotal thyroidectomy patient who's recovering one day in short stay surgery, going home the next day. All of a sudden overnight, everything starts to surge, right? And you think infection and fever and tachycardia, and you're like, oh, let me hydrate him because he's post-op. Maybe he lost a lot of blood. He wasn't supposed to lose a lot of blood in a thyroid surgery. So infection, surgery, trauma, suddenly stopping antithyroid meds, although that has to go on for a long time. But suffice it to say, those incidental hospital triggers can set the stage for this in a patient with untreated or undertreated hyperthyroidism. So the hormone levels are higher in regular hyperthyroidism. It's about the sudden shift, not just the number. Emergency management, obviously stabilize the patient, airway, breathing, circulation, electrolytes, beta blockers, antithyroid drugs, iodine solution, Lugol solution, things like that. Oh, there is a role for steroids here because remember, it's an inflammatory process. So glucocorticoids, hydrocortisone, dexamethasone, that can reduce T4 to T3 conversion, and that will treat the potential or relative adrenal insufficiency to calm the inflammatory process. And we'll talk about adrenal insufficiency at the end of the lecture as well. So any hyperthyroid patient with fever, delirium, cardiovascular instability should be presumed the thyroid storm until proven otherwise. This is your rapid response ICU consult immediate. All right. Let's take a 5-minute break. We're going to do little breaks here. We'll do parathyroid disease, and then we'll go on to diabetes and adrenals. So let's take a 5-minute break here. We'll do parathyroid to come back. Okay, so we're going to go on to talk about parathyroid disease. Now, parathyroid function is something to review if you're not that familiar with it. But the biggest tell here, the thing that sets off the I should go look for a problem, is when you see an abnormal calcium level. So what's the primary regulator of serum calcium? Well, it's the parathyroid hormone, PTH. And this maintains calcium and phosphate balance through bone, kidney, and intestine. So what does PTH do to the bone? Well, it increases bone resorption, and this is what releases calcium into the bloodstream. So bone resorption is what's releasing the calcium into the bloodstream. So what does PTH do in the kidney then? It increases renal reabsorption of calcium and increases phosphate excretion. And what about the intestines? Well, it indirectly, PTH stimulates vitamin D activation, and vitamin D boosts intestinal calcium absorption. So what are you realizing here is that PTH regulates the interplay of these organs in order to get calcium in and out of the bone to maintain homeostasis in the bloodstream, and that's directly affected by the amount of vitamin D absorbed in the diet. So if someone is vitamin D deficient, you may find it very hard to get the calcium level right. Now, this is more important, especially during the developmental years. And so, because that's when we're laying down a lot of our bone matrix, essentially. And so, geez, what's wrong with my slides? All right, so let's talk about parathyroid disorder. So how do you categorize it? Well, there are 3 ways. You can either have primary hyperparathyroidism, which is autonomous PTH overproduction. Remember those 3 buckets. You're making too much, you're making too little, or you're resistant. So primary hyperparathyroidism, this is autonomous PTH overproduction. Secondary and tertiary hyperparathyroidism, that's PTH is elevated due to chronic hypocalcemia. And who can have chronic hypocalcemia? Your CKD patients. And then, of course, there is hypoparathyroidism, which is essentially the deficiency or resistance to PTH. Hyperparathyroidism is the most common cause is a single benign adenoma. Something is causing an ectopic secretion in about 85 to 90% of cases. And the hallmark pathophysiologic finding is the excess in PTH leading to bone resorption, leading increased calcium reabsorption is happening, and then increased phosphate excretion and vitamin D activation. All of that is up. The classic features, and you may have heard this, stones, bones, groans, and psychiatric overtones. Well, what happens when that excess calcium is there is you're setting the stage for kidney stones, and you're pulling calcium from the bone. So the bones start to hurt, right? And then you have GI distress. And psychiatric overtones is the depression and cognitive changes that can happen. Incidentally, when they have this, they will also develop polyuria from the increased hypercalcemia, because essentially there's a solute going through the kidney and the water is chasing it out. The diagnostic rule of thumb for hyperparathyroid is elevated calcium with an inappropriately high PTH. Elevated calcium with a high PTH, that's going to make you think of primary hyperparathyroidism. That's the classic lab pattern: high calcium, high PTH, and low to normal phosphate. So you should generally know that calcium and phosphate go in opposite directions. The other thing is you might notice a high vitamin D level. So how this is different, though, from, say, secondary hyperparathyroidism that you might find in chronic kidney diseases, in CKD, the parathormone is high, but the calcium is usually low to normal. In chronic kidney disease, the parathormone is high, but calcium is usually low to normal. So what is the definitive treatment of primary hyperparathyroidism? Well, it's surgical removal of the adenoma, oftentimes a parathyroidectomy. The non-surgical options is, watch and wait for mild cases. Maybe you give some bisphosphonates to non-surgical candidates to try and absorb up that excess calcium. Now, hypoparathyroidism, the other side of this, is defined by a state of deficiency, obviously, of parathormone level, either decreased secretion or action, leading to hypocalcemia. So in hypoparathyroidism, you will see a matching low calcium. The most common cause of this is surgery, meaning you've removed the parathyroids. So say after a thyroidectomy, there may have been an incidental parathyroidectomy as well. Also, some autoimmune syndromes can cause this. Some genetic disorders like DiGeorge syndrome, and there might be some mutations of the calcium sensing receptor. Also, magnesium deficiency can cause hypoparathyroidism. So what happens if PTH is low? Well, bone resorption decreases and renal calcium and reabsorption falls, and then vitamin D activation drops. And the result is this hypocalcemic state with a hyperphosphatemia. Remember, the calcium and the phosphate are going to go in opposite directions. So clinical recognition is important. How do patients present acutely in this case? Well, tetany, and I've never seen this, carpopedal spasm, seizures, even laryngospasm. These are life-threatening. Laryngospasm is life-threatening regardless of what's causing it. The classic bedside stars are Schuvasteck signs. So, when you tap on the cheek and you continue to get a twitch, that's due to the low calcium, by the way. Facial twitch, the Trousseau sign, when you pump up the blood pressure cuff and you get the twitch in the arm. And then also some chronic presentations, someone that presents, say, with paresthesias, fatigue, cognitive decline. Well, in an elderly person, you may be inclined to chalk that up to mild cognitive impairment or some sort of psychiatric manifestation. But the reason I bring this to your attention is because psych will say, go get cleared in primary care, and you might be the primary care during the clearance. And this should dawn on you that maybe I should look for this, because I don't want this person to wind up unnecessarily on medication when they really are having, say, a condition we can do something about. The key diagnostic triad: low calcium, low parathyroid, high phosphate, and that's your diagnosis for hypoparathyroidism. So take a look at this chart here. So what you have here is a chart of hyperparathyroid next to hypoparathyroid. Primary cause, hyperadenoma, hyperplasia, carcinoma. Hypo, surgeon, genetics. Pathophysiology, hyperparathyroidism, excessive PTH, increased bone resorption, increased renal calcium reabsorption, increased vitamin D, hypercalcemia, the exact opposite in hypoparathyroid. So pay attention to these middle three, calcium, phosphate, and PTH. Those are going to be your tells. Those are your lab tells to diagnose this condition. PTH, vitamin D, phosphate, and calcium. I would circle that, remember that, mark that down. You might see some labs on a test and say, what is the condition likely here? All right, guys, so now here we are going into type 2 diabetes, type 1 diabetes, pancreatic function. This may be old hat to many of you because it's among the most common conditions you've probably encountered in healthcare, but here we go. So what is the problem here? Well, the problem in diabetes is we are having some beta cell dysfunction. The beta cell is really the star of the show in terms of glucose regulation. Beta cells account for about 80%. And they produce insulin, and acting as glucose thermostats. When the beta cell gets destroyed, that's what we're calling type 1 diabetes dysfunction. Unlike type 2, that can happen over time, but that's not the primary dysfunction there. The unique thing about the beta cell is the insulin secretion. It's biphasic. So basically, you have a rapid first phase stored insulin release followed by a sustained second phase of newly synthesized insulin so that your blood sugar can remain relatively stable, even if you eat a pack of Sour Patch Kids. Now, there is a cell in the pancreas that counter-regulates, and that's the alpha cell. About 20% of the pancreatic cells are alpha cells, and they release glucagon. So does your liver, which prevents hypoglycemia by stimulating glucose production. So in long-standing diabetes, the glucagon response is often impaired. So the delta cells now, these are the brake pedals of the pancreas. They account for about 10%. They secrete somatostatin, and this inhibits both insulin and glucagon, which helps fine-tune the balancing act of your blood sugar. How do insulin and glucagon work like the yin and yang of our metabolism? Well, insulin is anabolic, and this promotes glucose uptake via GLUT4, glycogen synthesis and fat storage. Glucagon, on the other hand, is catabolic, and this promotes glycogen breakdown, gluconeogenesis, and ketogenesis. Together, these two will balance the storage and release of energy. So what happens in a fed state, say, after you've eaten a meal? Well, rising glucose gets the beta cells to secrete insulin. The tissue takes up the glucose and stores it. The alpha cells suppress the glucagon because you're taking in glucose, so we don't need to have that. But what we're going to need is a normal blood sugar in 2 hours because the food is going to have left the stomach at that point. So what happens in a fasting state between meals? Well, the glucose falls, the alpha cell will release glucagon, glycogen breaks down, gluconeogenesis kicks back in, the insulin drops, the glucose is maintained at that 70 to 100 level mark. So which backdrop hormone also raises glucose when needed? And we'll talk about this more when we get to the next section, when we talk about the adrenal axis, but so suffice it to say, cortisol is not all bad. Cortisol and growth hormones and epinephrine are what we call the backup hormones. These are counter-regulatory hormones that increase glucose via gluconeogenesis, lipolysis, and glyconeogenesis. This is important because when you're stressed out, you need sugar. Now, maybe you all of a sudden start eating when you're stressed out, but your body's got a backup plan in case you can't get to the food in time. So this physiology clinically matters because when the balance is disrupted, we get the manifestation of these two different disease states we're going to talk about. So type 1 means no insulin production, and type 2 means insulin resistance with beta cell dysfunction eventually. And then the result is this chronic hyperglycemic state, but as you can see, they're due to two different reasons. The chronic hyperglycemic state, that glucose toxicity, is going to be the thing that eventually leads to nerve damage and vascular damage. Okay. All right, so let's take a look here at type 1 diabetes. Type 1 diabetes, this is the simplest definition. It's an autoimmune disorder where the body destroys its pancreatic beta cells, leading to, and this is the key phrase here, absolute insulin deficiency. Type 1 is not only a childhood disease. It commonly occurs in childhood. It peaks in childhood, adolescence, but it can occur at any age. Remember, it's an autoimmune process in which the beta cells are destroyed. What makes type 1 diabetes absolute compared to type 2 is that in type 1, patients produce no insulin at all due to complete beta cell destruction. Whereas in type 2, that's a process that happens over time, but the primary factor is the insulin resistance. Now, there is a genetic component that can set the stage for type 1 diabetes. The HLA gene on chromosome 6 accounts for about 50% of the risk. It's a high-risk haplotype. So the gene specifically is DR3DQ2, but you don't need to know that in DR4DQ8. Suffice it to say, there is a genetic component that can set the stage for type 1 diabetes to occur. There also can be some environmental triggers that set off an autoimmune attack, like what? Viral infection, an enterovirus, Coxsackie virus. These all can activate autoimmunity in a genetically susceptible person. So what that means is when the autoimmune inflammatory process sets off, we don't know exactly where it's going to land. But if it lands here at the pancreas, we're setting the stage for what we are calling a type 1 diabetic state. So what happens in this autoimmune inflammation activation state is you get something called molecular mimicry. So the viral protein resembles the beta cell protein. Then you get T cell activation where that helper T cell attacks the beta cells as antigens, essentially. And then you get autoantibodies that form. That's when the beta cells, rather the B cells, make antibodies years before the symptoms occur. So remember, we started lesson 1 off with inflammation, and we did lesson 2 with infection and adaptive and innate immunity. And here's where it's coming into play again when we talk about these autoimmune processes and how they set the stage for various pathologies to develop. So how much beta cell loss is needed, do you think, before diabetes appears? Remember, the body is remarkably adaptive. It's doing a great job to keep us alive. So the thing, you can probably go about 80 or 90% before beta cells are destroyed. So that's a long time for disease to follow. Now, there are some major autoantibodies used for diagnosis, and you can draw these antibodies. They are GAD65, IA2, ZNT8, and IAA. At least one detectable of these antibodies is about 80 to 90% accounted for a new diagnosis. Now, the clinical pearl you need to keep in mind is multiple autoantibodies present equals a higher risk of rapid progression. But even if they are antibody negative, you can still develop type 1 diabetes. This is just to tell you that the autoantibodies are a high risk, but it's only like 85 to 90%. That means about 5 to 10% or 10% or so is still unaccounted for. So what happens here? Well, what happens is metabolically, when insulin is absent, you get obviously hyperglycemia. The sugar cannot enter the cell, but we're starving. So what are we going to do? Well, we're going to break down the fat. So we get ketogenesis. Fat breakdown leads to ketoacidosis. Unfortunately, a lot of times type 1 diabetes, the first time you ever see it is when a patient is in the emergency room in DKA. So as a result of the body starving for sugar, it breaks down fat, which releases the keto acids, but also it needs to break down protein. And so that's the catabolic phase. So we have muscle breakdown for glucose production. And this requires a large amount of water, and they can't possibly drink enough, and they're diuresing. So we get the picture of also dehydration. So this DKA picture can often be the first tell, because if you think about it, most kids are generally healthy. We don't go screening them for type 1 diabetes randomly. So we generally, unfortunately, wait for a problem to occur, and then that's how they get found. Now, there is something called the honeymoon period in type 1 diabetes. That's that temporary phase after the diagnosis where you may have some beta cell recovery when they get insulin because they're not exactly taxing the heck out of it. But after a while, it completely fails. Type 1 diabetes is an autoimmune disease with predictable phases, identifiable antibodies, and a dangerous metabolic consequence if untreated. And oftentimes, unfortunately, you don't tend to pick it up until they come to the ER with DKA. So let's take a look here at this case, type 1 diabetes case. What stands out to you should be the polyuria polydipsia. Your mind should immediately start to think about osmotic diuresis from glucosuria, right? The sugar is high, the body's washing out the sugar and the water. Of course, this person's going to have weight loss because we're having protein breakdown and fat catabolism despite adequate caloric intake. The sugar is not able to enter the cell. The body's looking for another means of energy. So it's breaking down your macros, essentially. And what are the macros? Well, anything that has new calories is a macro. Carbohydrate, fat, protein. The body needs its macros. And then because they're starving, they're constantly hungry. That's the polyphagia. So despite having a high blood glucose, they're hungry all the time. And also fatigue and inability to utilize glucose for cellular energy because they're not able to get it into the cell. So how do you confirm a diagnosis of diabetes? Well, standard criteria, right? Fasting plasma glucose greater than or equal to 126 on 2 separate occasions. Or you can have a random plasma glucose, meaning not fasting, greater than or equal to 200 with symptoms. Symptoms are what? Polyuria, polydipsia, polyphagia, weight loss. Or you can do an oral glucose tolerance test. And it's going to be greater than or equal to 200 at 2 hours after that 75-gram glucose load. This is what we do in pregnancy, by the way, at the glucose tolerance test to diagnose pregnancy, gestational diabetes. Or the easiest thing we're doing now most of the time, because you can tack on the blood test, is a hemoglobin A1C of greater than or equal to 6.5. Although less reliable in sudden onset type 1. Because why? That A1C is giving you a 3-month average. They can develop it sometime within that 3-month window, and your number may be falsely contained. So that's something to keep in mind if you're going after type 1 diabetes initial diagnosis. So the thing to keep in mind about these people is DKA is often if they come into DKA, we don't wait to confirm diabetes. We immediately check a glucose, ketones, and start treatment right away because they basically declared themselves. So how do you distinguish between type 1 and type 2 diabetes? Because remember, you can develop type 1 outside of childhood, right? We have maturity onset diabetes of youth, and we also have late adult diabetes, late onset adult diabetes. The distinguishing test to tell the two apart is the C-peptide level. So the way it reflects is this. If you have type 1 diabetes, you will see a very low, less than 0.6 C-peptide level. If you have type 2 diabetes, you will have a normal to elevated C-peptide. The C-peptide is basically saying that my cells are producing or not producing insulin. So the big 4 autoantibodies to keep in mind with type 1 diabetes are the glutamic acetic dicarbylase, which is GAD65. It's most commonly present in about 80% of cases. Insulinoma-associated protein, that's the IA2, found in about 60 to 70%, especially in younger patients. ZNTA, which is the zinc transporter, found in about 80% of newer, and this is a newer marker. Quest has this, by the way. And then IAA, insulin autoantibodies. This is seen mainly in children, and it's less useful once you've started insulin therapy. So you will draw the labs on the visit, prescribe the insulin, send for testing. Your result will be accurate because you're treating what you have. You don't have to have all of these to make the diagnosis. One is good enough. Now, the percentage of type 1 diabetic patients that have at least one positive autoantibody is about 90%. If all are negative, then that's how you make the diagnosis of maturity onset diabetes of the young. Because the reason it's negative might be that we're starting to exhaust our insulin production. They may be insulin resistant, and they're really having what we would call a type 2 picture, but it's still called, it's in the type 1 range because of age. So we call it MODY, maturity onset diabetes of the young. There's another one called latent autoimmune diabetes of adults. It's an autoimmune process, but we're kind of discriminatory. We just say you're old and have it, therefore it's type 2. But you can distinguish depending on the antibodies and C-peptide production. The immediate priorities, obviously, is if you suspect or you're going to deal with DKA, are the urgent findings: sodium bicarb less than 15, anion gap of greater than 12, arterial pH of less than 7.3. The urine analysis will have large ketones, high specific gravity because it's very concentrated. And then, of course, you always want to check for comorbid conditions. So thyroid function test, TSH-free T4, always when you're doing this. About 30% of type 1 diabetics will also have autoimmune thyroid disease. And of course, you want to do a lipid panel for baseline cholesterol and triglycerides, since cardiovascular risk is elevated. The workup for type 1 diabetes is about confirming that the patient has diabetes and determining if it's autoimmune type 1 or another form. And it's the C-peptide that you would draw. So you could do a C-peptide hemoglobin A1C serum insulin as your crude way and pick one autoantibody, and then you could make the diagnosis that way. So what these autoantibodies are doing is essentially they are against the beta cells. The beta cell proteins show the diabetes is autoimmune. So if you're positive for at least one of them, that confirms autoimmune destruction. Let's see if there's questions here. Can you develop type 1 due to environmental factors? Yes, but I'm not talking about necessarily as forever chemicals or proteins. Something in the environment may trigger that autoimmune or inflammatory cascade to start. Could be a virus, could be maybe you were genetically predisposed, could be a sickness, could be an environmental, could be a surgical, could be a lot of things that trigger it. And the problem is, of course, we live in the world now of correlation being confounded with causation. So for example, might you get a vaccine and then develop it? Did the vaccine cause it? No, the vaccine didn't cause it. What had happened was you are genetically predisposed that any stress response would have triggered it. Does that mean we should gamble and not vaccinate you because what? You're invincible? No. The conundrum is you're genetically predisposed and we can't tell. And there's no way to really tell that. So then that's the conundrum. But people say, oh, the vaccine caused. No, correlated. You happen to get a stress and then you set the cascade into effect. So why do we use insulin in type 1 diabetes? Because it's a life-sustaining therapy. This is not just another blood sugar medication. You have to realize in type 1 diabetes, they're not making insulin. So the beta cells are destroyed. Zero endogenous insulin. Unlike type 2, where diet and oral meds can be okay. Insulin replacement is mandatory for survival, and this requires a lot of effort because, you know, kids don't want to give shots all day long. And the technology's come a long way from Lantus. We are now onto insulin pumps and continuous glucometers and insulin pumps that auto dial in and they talk to your iPhone, and you can do all kinds of things where you have to be careful, though, because they can overshoot, but there's a lot of governors in place. So what happens metabolically when the insulin is absent? The body shifts to a catabolic state, fat breakdown, protein breakdown, hyperglycemia, ketosis, muscle wasting. That's what we're aiming for. So a blood sugar of say 400 to 800 in DKA, even with no food intake, that's because the counter-regulatory hormones such as glucagon, cortisol, and growth hormone and epinephrine are just surging unchecked, right? There's no insulin to govern your production. So without insulin as the conductor, the orchestra is going to play out of control. So this promotes the gluconeogenesis, glycogenesis, and lipolysis. So how do you replicate normal physiology with insulin therapy? Well, they use a basal bolus strategy. So this was like in the old days, glargine or Lantus at bedtime, and then pre-meal, pre-prandial with a sliding scale and that sort of thing. That's kind of the traditional way. The automated ways are basically doing some version of basal bolus strategy. Now, there is a way to calculate the insulin needs. I'll briefly give it to you. You can just randomly do the formula. You'll find out in pharmacology. And some people just say, I start with 10 and go up by 20% every week until I reach a desired goal. And that's another way to do it. You'll need to be in good contact with your patient. Telehealth has made this much easier. But in general, you're going to start at 0.6 to 0.8 units per kilogram per day, 50% basal, 50% bolus. And then you're going to do carbohydrate ratio counting. And that's all I want you to know about that for now. I'm not going to test you on this. I'm just giving you this information so you have some general information to kick around. I'm more interested in you understanding the pathophysiology of type 1 and type 2 diabetes. Of course, the thing that makes insulin therapy imperfect is that the subcutaneous absorption can be delayed and variable depending on where you inject it, the temperature, the quality of the skin, essentially all those factors. Also keep in mind that injectables do not get liver first pass effect. So it's harder to suppress hepatic glucose production because it's not happening in the normal hepatobiliary tree. So the liver may just start pumping out more sugar in response. And so that's what makes titrating insulin a lot harder. What you want to do is ask yourself, if I were a pancreas, what would I be doing now? Right? That's how you know. Your job is to approximate the physiology of the pancreas with insulin therapy. And they will be able to tell you better about themselves as they proceed. Well, the next type of diabetes we're going to talk about is type 2, and this accounts for about 95% of diabetes cases. This is the most common. The issue here is not a lack of insulin, it's that the insulin doesn't work well. So think of this as having lots of keys, but the locks are all jammed. And the core pathology here is that there is insulin resistance. Muscle, fat, and liver stop responding properly, and the glucose is not able to enter the cell. You will eventually get beta cell dysfunction. The pancreas is going to overwork to make more. It's that negative feedback loop. There's high sugar, make more, high sugar, make more, high sugar, make more. I'm making as much as I can. I'm tired. I've stopped making anymore. I can't go on. The beta cell dies, and then you need insulin ectopically. Okay, so gradually it burns out. The liver effect keeps making glucose even when the blood sugar is already high because the insulin has already switched off and has just given up the ghost. So what you have here is a condition, because the body's really good at compensating, it can lie silent for many years. So I will tell you that most patients have been diabetic for about 10 to 15 years before they were ever diagnosed. We did a don't ask, don't tell. You never checked. They come in, you finally find the high A1C, and you're like, where did all this damage come from? Well, you have been fighting a losing battle for many years. It's gradual onset. The body does an amazing job at compensating. So when the glucose gets high enough, the symptoms appear, right? But it took a while to get there. And the symptoms are the polyuria, polyphagia, polydipsia, and fatigue. So unlike type 1's dramatic onset, type 2 creeps quietly, which is why when you get there, you see these high-risk patients with a lot of comorbidities. No, latent autoimmune diabetes is not the same thing as diabetes 1.5. Also, let me just put this here. You are noticing the word diabetes applied to a whole bunch of conditions lately because they're trying to say it's like diabetes. So just today I heard they're calling ADHD like type 1.5 diabetes. And once I saw them calling Alzheimer's disease as type 3 diabetes because there may be some insulin resistant components to those conditions. Now, that's not what I'm talking about here. No, I don't think it's type 1.5 diabetes when you eventually develop it. But you're going to see that used a lot. So it's going to be really important that you clarify exactly what the person means when they come in with this sort of information. Thank you for the question. All right, so unlike type 1 diabetes, which is dramatic at onset, type 2 is a slow creep. And the main thing to remember here is it's insulin resistance with progressive beta cell failure leading to chronic hyperglycemia. And it's often asymptomatic in the early phases. All right, now take a look here at this type 2 diabetes case presentation. What you have here is a 54-year-old male whose peak demographic for type 2 diabetes. So men often present later than women because we're less likely to seek routine care, right? We are not going to the doctor. It's a bunch of quacks. They ask too many questions. I'm never going. My average patient in my private practice, my average male patient, when I finally get to see them, will tell me, I have not seen a doctor in about 10 to 12 years. That's average for men. 10 to 12 years. The last time they probably saw a doctor was in college or before a sports physical or their pre-employment physical when they first started working, and they take a don't ask, don't tell approach to the rest of their health problems. So what you'll notice in this case here is a gradual onset. This is not the acute type 1 presentation. The symptoms developed over months to years as glucose slowly came up. He's gained 22 pounds over 2 years, which is a classic pattern, by the way. Progressive weight gain preceding the diabetes diagnosis. The insulin resistance contributes to the weight gain, which worsens the insulin resistance, and this vicious cycle ensues. Central adiposity is a huge driver of insulin resistance. The other thing to keep in mind here is the strong genetic component. Having a first-degree relative with type 2 diabetes increases the risk by about 2 to 6-fold. So always ask about family history. Now, some other things you'll notice here is this person is technically hypertensive and has a BMI of 32. Yes, I know BMI is going out of style, but suffice it to say, most of your literature is written about BMI. So he has two components of what we call the metabolic syndrome, which we'll cover more at the end. But the two components here, the hypertension and the obesity, commonly coexist with the type 2 diabetes. And it's not just a glucose problem. The other thing you'll notice here is the central adiposity with a waist of 42 inches. So visceral adiposity here, middle body fat, is the key driver of insulin resistance. Waist circumference of greater than 40 inches in men is a major risk factor. This isn't just about being overweight, it's metabolically active fat. So I'd rather he be fat in the legs and the butt than the belly, but that's not typically where it happens. In the South, they call this Dunlap disease. You sit down and your belly done lapped over your belt. We could tell you're fat enough just that way. You don't need to take out the tape measure and do it. If that happens, that's considered central adiposity. That is an indicator or one of the components of metabolic syndrome and a risk factor for developing type 2 diabetes. There's another condition that can develop here called acanthosis nigricans. Now, this is a pathognomonic for insulin resistance. If you see this dark, velvety skin change result, this is from having too much high insulin. The body has been working hard to bring down that blood sugar, and it's not responding because you're insulin resistant. And so this stimulates skin cell proliferation. If you see this, check a glucose level and an A1C while you're at it. Another thing you may notice is decreased foot sensation. Now, these are already showing signs here of diabetic neuropathy at presentation. Now, this suggests that he's had undiagnosed diabetes likely for several years because the glucose doesn't damage the nerves overnight. There's other comorbid conditions that can further worsen it, but some of the differentials you need to consider is because of the central adiposity and the hypertension and the glucose intolerance likely, this is really part of this pathophysiologic spectrum of type 2 diabetes. Other things you need to think about though, hypothyroidism. Why? It's got fatigue, weight gain, maybe some depression can overlap, but hypothyroidism typically causes cold intolerance and doesn't explain the nocturia or the acanthosis nigricans. Cushing syndrome can also be considered in your differentials because of the central adiposity glucose intolerance, but Cushing's typically causes purple striations and a moon face and proximal muscle weakness. That's not seen here, and we'll talk about Cushing's in the next section. Obstructive sleep apnea is an excellent consideration, very common in obese patients and can cause fatigue. Also, it often coexists with diabetes, and the nocturia could be as a result of the frequent awakening rather than glucose diuresis. And I will also say this, if you don't effectively treat the sleep apnea, you are often going to not be able to treat the diabetes because they're having a major stress response of hypoxic events overnight. Oftentimes, you will find that A1C gets normal simply by just fixing the sleep apnea rather than continuing to chase them with insulin and meds. The problem, of course, is CPAP compliance, which is very low. So therein lies the problem. The way you do it, by the way, is you don't say slap on the mask and go for 8 hours. You do 15-minute intervals, you nap with it, you doze with it, you play with it, you desensitize yourself so you get used to it over time. You don't just say, here's the mask and go for it for the next 8 hours. It doesn't happen. They rip it off in the middle of the night. They feel like a failure, and the thing just sits there, and then they get charged if they don't use it. The important thing to note here is the constellation of symptoms. Again, we're not memorizing, we're looking for pattern recognition. Middle-aged man, central adiposity, family history, gradual symptoms, acanthosis nigricans. This is all screaming type 2 diabetes. So the key is to recognize the pattern before ordering the test. That's how it's supposed to go. You do the test to confirm, not to go fishing. So notice here that he already has neuropathy and hypertension, which reminds you that type 2 diabetes is often diagnosed late, and it's a silent killer, which has done a lot of damage. He's got metabolic syndrome here, not just type 2 diabetes, which means there's a much higher risk of cardiovascular disease. And the goal is not just glucose control, which often takes center stage, but also weight loss, blood pressure control, renal protection, et cetera. So based on this presentation, what do you think your next step would be? This is all you have. Type in the chat what you think your next steps would be. What are you going to do for this person? Have you confirmed the diagnosis? Do you know for sure he has diabetes just because I put that on the slide? Well, we don't. So your next step has to be confirmation. So that's going to be a hemoglobin A1C or a fasting glucose. A1C is easier, but also looking for complications. So maybe you're going to check a lipid panel, a urine random microalbumin. You're going to send them to ophthalmology for a dilated eye exam. You can do a monofilament test yourself, or you can get them to set up a relationship with podiatry to put them on a rotation to clip those toenails and look for foot complications as they go on. Classic type 2 diabetes presentation, gradual onset, multiple risk factors, complication signs at the presentation. This is your prototypical picture to keep in mind. So how many ways can you diagnose diabetes? There are 4 ways. 4 ways. Any one of them is good enough. Fasting plasma glucose greater than or equal to 126, oral glucose tolerance test greater than 200, hemoglobin A1C greater than or equal to 6.5, random glucose greater than or equal to 200. Pick a test, any test. One will do and get you in the door. And what are you in? Well, lifestyle management, because each of these tests reflects a different aspect of glucose metabolism. So you can pick any one, but I want you to think through what exactly are you testing with the respective test. So if you do a fasting plasma glucose, there you're checking hepatic glucose output, right? Fasting plasma glucose, is the liver the culprit? Oral glucose tolerance test. What you're testing there is the ability to handle a carbohydrate challenge. Can you eat, and do you produce enough to overcome? That's how you're testing specifically with oral glucose. A1C, what you're looking for there is, what is your long-term average glycemic exposure? Random glucose with symptoms, that's the real-world test. Real-world confirmation in an acutely ill patient. So you might ask you to think through fasting plasma glucose. What is it you want to aim your treatment at? So depending on the test you choose, you can target your treatment at things that enhance glucose, that inhibit glucose production or increase insulin sensitivity. So that's how you can figure out what to pick first. So how do you interpret it? Plasma fasting glucose less than 100 or an A1C of less than 5.7. Normal, continue with your life. Fasting plasma glucose of 1 to 125, A1C 5.7 to 6.2, pre-diabetes. Not borderline, pre-diabetes. They're already at high cardiovascular risk. They have about a 30% chance of progressing to type 2 diabetes in about 5 years if left untreated. So this is the one you're going to really do lifestyle changes. Get the personal trainer, get the nutritionist, sign up for the gym, drink your water, sign up for Weight Watchers. Maybe now we have GLP. They might qualify for that, only if they have the obesity though. Definitive diabetes, fasting plasma glucose of 126 or greater, A1C greater than 6.5. And those are voted on every so many years by the Endocrine Society and the Diabetes Society, and then you will see that number progressively come down. When I first started practicing, that number was 7 to make the diagnosis. So now it's come down in the 20 years I've been practicing. So when do you need to confirm results? So if you get a borderline test, repeat that test or use a different method. If the test is dramatic or severe, no need to repeat. You have the diagnosis. So the routine screening is preferred. We recommend the A1C because no fasting and it's convenient. What do you do if a test disagrees? So like say you have the A1C of 6.2, the fasting plasma glucose of 132. Both indicate diabetes. So at that point, you're going to err on the side of making the diagnosis. Don't get stuck debating the decimal point. Err on the side of caution because basically this person is moving in that direction. And the diagnosis will then be able to get approval for the meds you're going to prescribe, right? Because when you prescribe, insurance may give you resistance if the ICD-10 does not match the prescription. Or the lab will not be approved if the ICD-10 code does not match the prescription. So that's why you can make the diagnosis at this time. The bottom line is any of these methods to diagnose are acceptable. Pick one, go with it, repeat it if it's borderline. Err on the side of diagnosing than not diagnosing if you have equivocal tests. One says yes, one says no. So let's talk about how we're going to treat this. Now, diabetes treatment has come a long way in the many years, and I'm going to spend a little time on how do we treat this. So you have obviously metformin. That's the hepatic glucose suppressor. So if you notice that they're waking up with a high blood sugar in the morning, that might be how you choose that. Thiazolidine-diones have gone out of favor because we found they're causing people to have heart failure, but it was a really good drug at low doses to increase insulin sensitivity. The one on the market now is pioglitazone. That's an adipose remodeler. It reduces insulin resistance. We also have a class called the secretagogues, and this used to be all there was when I was in my undergraduate. This is the sulfonylureas and the metagliptins. These are things that cause the pancreas. They squeeze the daylights out of it to get it to produce insulin. The problem in doing that, though, is you risk a hypoglycemic event because it's going to pump out insulin regardless of the food in the system. So that's a problem. Now, these are all the rage. The incretin-based therapies. We got GLP-1s. They came after the DPP-4s. The DPP-4s are the things like Januvia with the big DPP-4. Starlix was a secretagogue. Suffice it to say, the GLP-1s, you know who they are. They're on the news. They have Ozempic and Zepbound and tirzepatide, and depending on its indication, the name changes, but the mechanism is the same. The GLP-1s mimic the gut hormones. They boost insulin only when glucose is high. That's beautiful because then we don't have to risk hypoglycemic events. They suppress glucagon, and even better, they slow gastric emptying, which promotes early satiety, which means we get to gradually reduce that sugar into the bloodstream so we have a more even rather than a big old spike of sugar in there and we get toxic. There's another drug on the market that's been around for a while. We all poo-pooed this immediately. This was like the Invokana et al. This is SGLT2 inhibitors. This uses your kidneys to pull sugar out of the bloodstream. The problem with this is it puts sugar in the urine. Why is that bad? Well, turns out if you put sugar near the urinary meatus, anywhere near there, you're going to increase the risk of developing a candidal infection, especially in uncircumcised men. So if someone is going to be on this, you need to highlight the fact that while you may have beautiful blood sugar and you don't have oral candidiasis anymore, you may have candidiasis around the mucous membrane and in the urethra. So we need to just say, pay meticulous attention to your hygiene and check it out at your next visit, because if it's there, you're going to have to treat it and decide if this plus or minus is going to work out for you. But it's a good drug, has cardioprotective benefits. It's there. The alpha glycosides never seem to have caught on. It causes bloating and gas because it lets the carbs sit in the gut longer and break down and ferment. And that fermenting carbohydrate causes a lot of gas and bloating. And the gold standard, of course, is this insulin therapy. We would like to avoid this if we can, because it makes you hungry and makes you gain weight. But at the end of the day, we do need insulin to bring that sugar into the cell. So if you need it, you need it. So that's what we're going to do. So first-line drug. What's your first-line drug in any diabetes? Metformin. It shuts down excessive hepatic glucose production by activating the AMPK, and it's best for fasting, hyperglycemia, and the dawn phenomena. And what if the fat itself is the problem? Well, if you're lucky and you're feeling safe and bold, you can try a thiazolidinedione, the TZDs, the pioglitazone, but keep in mind you need to watch because it can exacerbate cardiac CHF. And how do we force the pancreas to make more insulin? Well, those are the secretagogues, the sulfonylureas. They're completely out of fashion at this time, but you use what you can where you are, depending on the formulary. So they're around, they can be somewhat useful, but everyone will look sideways at you if you prescribe it. The hottest drug on the market that we're using now to treat this is the incretin-based therapy. That's the GLP-1 receptor agonist to mimic the gut hormones. And so that is basically what we're getting at. If the beta cell eventually hits failure, that's when we will introduce insulin into the recipe. Now, my hope is that we get through adrenal and Cushing's in the next 30 minutes and recap with metabolic syndrome. So everyone, here we go. Buckle up. It's going to be a great ride. What triggers the HPA axis? What is the HPA axis? Why do we even have this? Well, I'm going to tell you. It's stress, any kind of stress. Pick a problem. I'll tell you how it stresses you out. Pathophysiology, your blood sugar is up. If I were to call on Brian right now, his heart rate will just shoot up in the air and his blood sugar is going to spike to meet this right now, right? I cause him stress. So professor, illness, trauma, surgery, even hypoglycemia. The hypothalamus releases corticotropin releasing hormone, the pituitary pumps out ACTH, and the adrenal cortex makes cortisol. This is a negative feedback system. The more that goes out there, the negative feedback, the more the cortisol goes up, the less the corticotropin releasing hormone and ACTH will be. This is why long-term steroids will suppress the HPA axis. And you can't just shut them off, because then you'll flip them into adrenal insufficiency, which we'll talk about on the next slide. But because it takes a while to wake up, this is the reason we have to wean the steroids. You can't just shut them off. So when should you check a cortisol to make a diagnosis? Well, our catecholamine surge between 6 and 9 in the morning. Our cortisol needs to feed that brain, feed that body, inhibit our glucose so that we have it for circulation. So if you do a morning cortisol and it is less than 10 micrograms per deciliter, your brain should say, oh, that's adrenal insufficiency. I need a higher cortisol in the morning than I do at night. And if your evening cortisol, which we want it to go down because you're starting to get ready to rest and digest, if it's greater than 7.5 micrograms per deciliter, then we're going to think Cushing's. So where is cortisol made? The adrenals. The zona fasciculata specifically. This is the body's master stress hormone. It peaks in the morning and it's lowest at night. Only the free cortisol is active, right? Just like the free drug. And what about aldosterone? I'll mention it now. Hang on to it for when we get to the cardiovascular system. But aldosterone, does ACTH control it? No, it does not. Aldosterone is produced by the adrenals as well, but it's the zona glomerulosa. And this is controlled mainly by angiotensin II. Hang on to that, because when we start talking about low perfusion states in the kidney and how this triggers the renin-aldosterone angiotensin system in the cardiovascular section, this will all make better sense. But suffice it to say, angiotensin II is the thing that's controlling the release of aldosterone. Now, how does aldosterone work? Well, it acts on the kidneys collecting ducts. And what it does is it increases the sodium reabsorption and potassium excretion. And what happens if both cortisol and aldosterone are gone, as in like the case with Addison's disease? Well, you'll get obviously hypotension, hyperkalemia, and an adrenal crisis if you think about what these hormones do in the body. And what happens if there's too much cortisol? Well, if there's too much cortisol in the body, you're going to get Cushing's syndrome. And what does that look like? Weight gain, hypertension, diabetes because of the glucose impaired metabolism, loss of the feedback control. And by the way, you can get the Cushing syndrome by taking the steroid or ectopically producing the steroid. And what happens if aldosterone is autonomous? What does that mean? Whenever you hear something's autonomous, that means it's outside the normal loop and something is causing it to secrete on its own. So primary aldosteronism can cause symptoms of hypertension and hypokalemia. So what is the key test to figure all this out? ACTH stimulation test, this checks adrenal reserves. This is the test that tells you about Addison's disease. The aldosterone-renin ratio, which you just draw through a serum test, this screens for primary aldosteronism. The bottom line is this. The adrenal cortex runs two systems in parallel. You have the HPA axis, that's for cortisol and stress, and the RAAS axis, that's for aldosterone fluid electrolyte balance. Disruption in either, dead if you miss it. So don't miss it. So let me talk to you now about the adrenal cortex system. So take a look at this slide here. This slide here has the HPA axis dealing with cortisol on one side and the RAAS dealing on aldosterone on the right side there. And what you can see are the main actions. That's what you really need to pay attention to. The HPA axis controls glucogenesis, blood pressure up, glucose up, increased vascular tone, and increased stress response, right? That fills you up. The RAS system, increased sodium reabsorption, increased potassium excretion, increased water retention through the sodium-potassium pump. That's what you need to keep in mind. And then what will happen is when they give you signs and symptoms, you will see how all this plays out. So what is Addison's disease? Remember those three buckets, too much, too little, or resistant? Well, Addison's disease is one of those too little conditions. Too little what? Too little adrenal hormone. It's adrenal insufficiency. The adrenal gland itself has failed. It causes low cortisol, low aldosterone, and low androgens. And how does cortisol loss affect the body? Well, you have a poor stress response. You get hypoglycemic. You'll have weak vascular tone. Think about all that. You ever hear of somebody that might be adrenally insufficient and they're off to surgery? What do we need to do? We give them a stress dose of steroid because they're not producing. And why do we do that? Because we're about to stress them out with a surgeon. You're going to cut them. And so all of this can't fire if the adrenals are not able to produce. So what does aldosterone loss cause? Salt wasting, low blood volume, hyperkalemia, metabolic acidosis. And what's the difference between secondary adrenal insufficiency? Well, if you have secondary adrenal insufficiency, aldosterone is spared. Only the cortisol is low. So what's the most common cause in the developed countries? Take a guess. Autoimmune adrenalitis, right? Everything here tends to be autoimmune. The body's attacking itself for some reason. We get T-cell destruction, often with the 21-hydroxylase antibody. And then what happens? The classic diagnosis, the triad, the thing you're going to listen for: hyperpigmentation, hypotension, electrolyte abnormality, that is to say low sodium, high potassium. That's the thing that you're going to notice to say adrenal insufficiency. And why does hyperpigmentation occur? Well, high ACTH stimulates melanocytes, and then that's what causes the darkening of the cells. What lab suggests to you Addison's disease? A sodium to potassium ratio of less than 30. So now I want you to go back to your clinical site, and any BMP you see, just calculate a sodium potassium ratio in your mind. You're not going to diagnose anyone with anything. You're just going to stare at the chemistry and get a whole new thing. They're going to think you're a psychic. You're going to stare at the labs longer, and they're going to be normally like, oh, I'm reading the tea leaves now. You're looking at the sodium potassium ratio less than 30. That's a red flag. You want to think about that. Now, what makes Addison's deadly if it's missed? It's the adrenal crisis. You need to have steroid on board. You will go into cardiovascular collapse and shock and die if you don't have enough steroid on board. So Addison's is rare. It's a very rare disease, but it is life-threatening. And there is a triad. So if you see the triad, you should confirm with labs and treat with hormone replacement therapy. So how does it look? Well, here's your case. You have a case presentation here. You will hear the story of extreme fatigue, weight loss, and dizziness. This triad of complaints should immediately make you think of adrenal insufficiency, not your whatever they're telling you of fatigued adrenals on the instant media, social media, whatever, Instagram business. Cortisol deficiency is basically going to cause impaired glucose homeostasis and reduced energy production. Aldosterone deficiency will cause the volume depletion, leading to poor tissue perfusion. The clinical correlation here is they're not just tired, they are actually cannot function normally. The weight loss with the cortisol deficiency will lead to things like reduced appetite, impaired protein synthesis, whereas the aldosterone deficiency is the thing driving the volume depletion, salt, and water loss. They may have GI symptoms, nausea, vomiting. This contributes to the poor oral intake. They will also have likely orthostatic hypotension. So the primary mechanism, of course, is what? That volume depletion. They may have hypoglycemia because that cortisol is not able to pump out enough sugar for them. That cortisol deficiency impairs gluconeogenesis. So the pattern is they feel worse when they stand up or exert themselves or have stress. They'll have these signs and symptoms. So in this 35-year-old male, he's at peak age for autoimmune Addison's disease. He's young enough that other causes of fatigue are less likely, making adrenal insufficiency the suspicious cause. Now look here at the timeline. He has fatigue and weakness for about 4 months. It's classic insidious onset. The autoimmune adrenal destruction takes time. Remember, autoimmune diseases do not just, it's here and dead. No, it takes a lot of time. The body's really good at adapting and trying to keep you going. Patients often see multiple providers before they arrive, but maybe it's in my head. Maybe I'll see the nutritionist. Maybe I'll see the shaman. I don't know who I'm going to see. But they go around and instant media tells them all the things that they should have or not have. Duration matters because an acute onset with symptoms suggests adrenal crisis or acute destruction, but the chronic course is the thing that's more typical, and you should pay attention to that. Progressively worsening over months, that's the classic pattern. 20-pound unintentional weight loss, that's worth paying attention to. Significant weight loss in a young male is always concerning for adrenal insufficiency, and it could be multifactorial. So I don't feel like eating, that's your cortisol deficiency, that affects appetite. The GI symptoms, nausea, vomiting, abdominal pain, reduced intake, metabolic effects, including impaired protein synthesis and muscle wasting, all of that should make you start to think. And the salt craving, that's the pathognomonic. I am craving salt. Why would you be craving salt? Because you're losing it somewhere, and this is the thing I need. Why are you losing it? I'm going to investigate. How will I investigate? Well, I'll tell you. This is one of the most specific symptoms for a mineral corticodeficiency. So they'll say things like, I put salt on everything, even fruit. I eat pickles straight from the jar. I crave potato chips constantly. I add salt to food that's already salty. All of that, red flag, red flag. Aldosterone deficiency is when the body is sensing sodium depletion. And the compensatory mechanism is this CNS drive of salt-seeking behavior. And the clinical significance is that the highly specific for primary adrenal insufficiency. So pay attention to what they tell you. Don't offer them other snack ideas. Order a workup. Okay. So let me see. All right. So the physical findings here in this case study, the blood pressure, 95/65. That seems relatively low. Heart rate of 92. That seems relatively high, even though it's within the normal range. An orthostatic drop of 20, that's significant. These vital signs are telling you the story of volume depletion. So hypotensive, healthy 35-year-old male, odd. This reflects a decreased cardiac output from the volume depletion. Remember the first day of class, I told you the 4 things that affect blood pressure, right? Recall those. So this is easy to examine. You can take a look and see here the dry mucous membranes, the diffuse abdominal tenderness, scarring around the areola, ACTH levels are elevated, and you can tell that by the pigmentation. So all of these are signs of essentially the underlying pathology, and the classic triad of hyperpigmentation, hypotension, weight loss. Those are the triad of Addison's, adrenal insufficiency. So what do we do? Well, here's the workup. So what's the first step you're going to do? Cortisol level in the morning. Between 6 and 8 a.m., we need a morning cortisol. The way you interpret it, less than 3, almost certainly it's Addison's disease. 3 to 10, it's suspicious. You got to confirm with future testing. If it's 15, likely not Addison's at all. What does the ACTH tell you? This helps localize the problem. A high ACTH and a low cortisol equals primary adrenal failure. If you have a low to normal ACTH and a low cortisol, then this is secondary or tertiary insufficiency. So why do Addison's patients get hyperpigmentation? Because the ACTH stimulates the melanocytes. What electrolyte pattern is classic for Addison's disease? Hyponatremia, hyperkalemia with a sodium-potassium ratio of less than 30. What's the gold standard to confirm the test? ACTH stimulation test with casinotropin. How do you interpret an ACTH stimulation test? Normal cortisol rises 18 to 20 micrograms per deciliter. Addison's, you get a flat response, less than 18 micrograms per deciliter. You give them ACTH, that's what you want to see happen. Other labs to pay attention to, you have a 21-hydroxylase antibody test. Adrenal CAT scan can be done. This is screening for other autoimmune. Also screening for thyroid, type 1 diabetes, pernicious anemia, because these autoimmune things can cause multi-system involvement. And if the patient is crashing or in adrenal crisis, first-line therapy is IV dexamethasone. It doesn't, you just need to first save the patient long enough to do the testing. The bottom line is morning cortisol is the test of choice when trying to diagnose Addison's disease. If you decide that endocrine is your bag, you can do very well with this. So let's talk about treatment. So the core principle in treating Addison's is replacing what's missing. So that's the glucocorticoids, which is hydrocortisone, or the mineralocorticoids, which would be fludrocortisone. How is cortisone dosed? Anywhere from 15 to 25 milligrams a day. You want more in the morning than you do at night, 2/3 to 1/3, 15 to 25 mg per day. Do glucocorticoid replacement doses cover the aldosterone need? No, they do not. That's why you have to give the fludrocortisone. I need you to hold on to the water. How should patients adjust during stress? Well, stress dosing, you double the daily dose for mild illness, 50 to 75 milligrams a day, for moderate. And then for surgery, you give 100 to 300 milligram IV in preparation for the surgery or trauma. The golden rule the patient needs to remember is when in doubt, take more. When in doubt, if you're not quite sure, always carry emergency hydrocortisone with them and a medic alert bracelet. So what is the lab guide for fludrocortisone? I'll tell you, this is used a lot off-label in the elderly, by the way, for sodium potassium levels. So if I have an elderly patient that's constantly getting orthostatic and falling down, I've done this in the home. This keeps them from needing to go to the hospital frequently for falls. So officially, though, you should follow the sodium potassium level and follow the blood pressure. Usually happens after they've had several trips to the hospital for orthostasis. Now, the emergency protocol for adrenal crisis is IV hydrocortisone, 100 milligram bolus, followed by 50 to 100 milligrams every 6 to 8 hours, in addition to saline and dextrose. The biggest danger in adrenal insufficiency is underdosing during stress. Always replace more rather than less. You can always taper it, but you can't undo a missed crisis. Okay. So now let's talk about the opposite. Now we have too much. This is Cushing's syndrome. So the difference between Addison's and Cushing's, Addison's is too little cortisol, Cushing's is too much cortisol. And what happens to body weight and blood pressure in Cushing's, do you think? Weight gain, central adiposity, and hypertension. hypertension. So why do Cushing's patients develop hyperglycemia? Well, obviously, excessive cortisol drives that gluconeogenesis and insulin resistance that we just talked about. And why do they get muscle weakness? Well, because of protein catabolism, especially in the proximal muscles. So what's the classic fat distribution feature here? This is the moon face appearance, the buffalo hump, and the truncal obesity. The skin findings that go with this one is going to be what happens when you have someone on chronic steroid use: thin skin, easy bruising, and wide purple striations. The most common endogenous cause of Cushing's is an ACTH secreting pituitary adenoma. The most common cause overall is exogenous steroid use. So this could be people on prednisone, say for asthma or some other autoimmune condition in which they have to be on prednisone. They will develop a Cushing's syndrome, but that's expected, and you're just going to have to deal with it because the worst problem is to not treat the autoimmune condition. So there are 3 screening tests you do for Cushing's. You can do the 24-hour urine-free cortisol. It's a burden, it's a pain, but it's a really good test. Late night salivary cortisol, hard to do. The lab is not open, so you could do it in the hospital, but you're not going to admit them for this. And also low-dose dexamethasone suppression test. That's another way to tell. You need at least 2 abnormals in order to make this diagnosis to avoid false positives. You can get something called pseudo-Cushing's from someone that has a long-standing depression or alcoholism or severe illness. Because why? Those are chronic stressors in which you are underproducing steroid that's necessary over time. Once you do confirm the diagnosis, you need to figure out if it's ACTH dependent, that is to say from the pituitary, or is it ectopic, or is it ACTH independent, that is to say it's coming from the adrenal gland. The bottom line in all of this is chronic cortisol excess is the clinical definition of Cushing's, and what we're looking for is the phenotype of central adiposity, the striations, the proximal weakness, the hypertension, and the secondary diabetes. And it's confirmed by cortisol testing. Then you classify ACTH dependence or not. So let's do the overview here. So we talked about metabolic syndrome, where endocrinology meets cardiology. This is the cluster of conditions, cardiovascular disease with type 2 diabetes. So the risk is twice the risk of cardiovascular disease and 5 times the risk of developing diabetes. The main issue here is the insulin resistance, and it's manifested by any 3 of the 5 criteria. You should be familiar with the 5 criteria of metabolic syndrome. Increased waist circumference, greater than 40 in men, 35 in women. That represents a central adiposity. Elevated triglycerides, greater than 150. Reduced HDLs, less than 40 in men, less than 50 in women. Elevated blood pressure, greater than 130/85. The pathophysiology there is the insulin resistance is leading to sodium retention and increased sympathetic tone. And then elevated fasting glucose of greater than 100, early marker of beta cell dysfunction. You should memorize these 5 criteria for metabolic syndrome. In fact, if you type into any chatbot search engine, you'll get this information. This is the bread and butter of primary care, and the prescription is no bread and no butter. Okay, so let's wrap this up. What is the best first test you do when you suspect a thyroid disorder? TSH. It's the most sensitive marker because small changes in the T4 cause huge shifts in the TSH. Always start there, then add on the free T4 if the TSH comes back abnormal. How do lab patterns help you know what the problem is in thyroid? If the T4 is low and the TSH is high, primary hypothyroidism. The thyroid is failing and the pituitary is yelling louder. If both T4 and TSH are low, that's secondary hypothyroidism. The pituitary itself is the problem. If the T4 is high and the TSH is low, that's hyperthyroidism, and the thyroid is overproducing and the pituitary is trying to shut down the signal. Well, what about subclinical disease? Well, subclinical hypothyroidism, TSH is elevated, but the T4 is still normal, and the thyroid is limping along, trying to do its thing. Subclinical hyperthyroidism is when the TSH is suppressed, but the T4 is normal. It's dangerous because even normal T4 levels still carry a risk for atrial fibrillation and bone loss. The most common cause of hypothyroidism and hyperthyroidism, Hashimoto's for hypo and Graves for hyper. These are autoimmune conditions in which we are causing the symptoms. Now, what are the life-threatening emergencies you need to recognize? Well, for hypothyroidism, it's the myxedema coma manifested by hypothermia, low temperature, bradycardia, altered mental status. Even with treatment, the mortality of missing this myxedema coma is about 60%, even with treatment. This is an ICU patient. For hyperthyroidism, it's thyroid storm, and that's easier to pick up, but you still don't want to miss it. Fever, tachycardia, CNS dysfunction. The mortality there is about 30%. Both of these demand ICU level care. Now, the special populations are the elderly. In the elderly, thyroid disease can look like falls, confusion, depression. Those are the classic symptoms there. In pregnancy, always use a trimester-specific TSH range. And don't forget, medications like amiodarone can cause both hypo and hyperthyroidism. The other one is lithium. Very important. What makes Graves' disease unique compared to other thyroid disorders? It's the exophthalmos. Causes proptosis, diplopia, and pain, not just the cosmetic vision loss problem. So urgent ophthalmology consult is essential in those cases. Now, a little bit on diabetes here, the red flags. When should you suspect DKA? Look for the Kussmaul breathing, fruity breath, and metabolic acidosis. And what are the labs that clinch the diagnosis for you? A glucose of greater than 250, a pH of less than 7.30, positive ketones, ICU patient right there. And what is the absolute pathophysiology in one line for diabetes? Type 1, absolute insulin deficiency. That's the problem. Type 1 diabetes, absolute insulin deficiency leading to unchecked lipolysis, ketogenesis, acidosis, and death. First treatment for all of these is it's a shock state, IV fluids, IV insulin, electrolyte supplementation, etc. What about hyperosmolar hyperglycemic state? How does that differ? Well, this is a hyperglycemic state. Usually the blood sugar is over 600, marked by hyperosmolality, minimal to no ketosis, and this is more common in older type 2 diabetes patients. Do you need to worry about mortality? Well, you do, because mortality is higher. It's about 20% in this patient. So you have to carefully give fluid resuscitation and insulin and watch out for the cerebral edema that you're going to cause. Now, let's talk about the adrenals and antidiuretic hormone disorders. Here are some red flags you don't want to miss. Adrenal crisis. Remember, hypotension, shock, abdominal pain, fever. It often comes after a stress, an infection, a surgery, someone with adrenal insufficiency as an underlying characteristic. So oftentimes you don't get to pick out the disease. You see the insult that tips them over, and then the workup begins after that. What labs fit adrenal crisis? Hyperkalemia, hyponatremia, hypoglycemia, right? Too much potassium, too little sodium, too little sugar. And how do you treat it? IV hydrocortisone. What's the danger in correcting hyponatremia too fast? A little beyond our purview, but osmotic demyelination is what you need to watch out for. So even though it's an emergency, you don't want to go too fast. This is highest risk in patients with, say, alcoholism. Remember, they can cause those pseudo-Cushing-like syndromes and the like. Metabolic syndrome. What clustering trigger should trigger screening in the patient? That would be things like central adiposity, hypertension, dyslipidemia. How do you frame the risk? Treat it like cardiovascular risk equivalent. It doubles the cardiovascular risk and quintuples the risk of diabetes. They'll say, I don't have diabetes, my sugar's normal. Yes, but your middle body fat, your triglycerides, your insulin resistance. That's where you're doing the aggressive lifestyle therapy. You'll add meds for blood pressure and lipids and glucose as needed. Let's see here. So, did you need to memorize? No, we're looking for pattern recognition. So the way you do that is you keep a high index of suspicion and treat first whenever it's life-threatening. So you're going to screen appropriately. Remember, TSH for thyroid, waist circumference for metabolic risk. Read the lab patterns and act on the emergencies. I need you to think systematically. Endocrine disorders touch every organ, so look for downstream effects. Don't just look at the organ. Think, what does this lead to? What might I see? What are the warning signs I need to pay attention to? And that concludes our endocrinopathy. Let me see what questions popped up in the chat here. Cause of autoimmune, because it's the hallmark of most disorders. A whole host of things can trigger autoimmune, everything from those stressors to insults, predispositions. Yes, do the workup, CPAP, very good. Latent autoimmune disease. Okay, great. No pressing questions there. All right, guys.